Chairman, I would like to welcome everyone who is present in the Council chamber and all those watching online to this meeting of the Health Scrutiny Committee for Lincolnshire. For those of us in the chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the Council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent to ensure everyone has the opportunity to ask a question. Please ask a maximum of 2 questions per item and to keep these succinct and concise. I would like to remind you all that your comments will remain accessible online. I'd now like to move into agenda item 1, apologies for absence and replacement members. Jess.
Thank you. Thank you, Chairman. We've received apologies from Councillors Scalise and Councillors Welbury and the Health Watch representative Liv Ball, and we have Councillor Margaret Geeney and Dean Odell replacing today. Thank you.
Thank you, and welcome back, Councillor Geeney. Nice to see you again, and welcome to the meeting, Dean. We'll now move into agenda item 2, declarations of members' interest. There's an opportunity for members of the committee to declare any pecuniary or other interest. Do any members have any interest to declare at this point? No, thank you. Oh, Councillor Kendrick.
Just my usual one, Chairman. I'm a governor of LPFT.
Thank you, Councillor Kendrick. We'll now move into agenda item 3, the minutes from the 17th of July. This is to confirm the minutes of the meeting as a correct record, and they are found on pages 3 to 15 of the agenda pack. As the committee has had the opportunity to read these in advance, I plan on taking these en bloc. Do I have a proposer for these, please? Councillor Atkinson-Sanders, and seconded by Councillor Cleaver. All those in favour, please show. Okay, that's supported. Those against? And any abstentions, please? Thank you. We've got 2 abstentions. Perfect. Thank you. They're accepted. I'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda, and my supplementary announcements were circulated via email on the 10th of September. I'd like to take these together, and if there are any content that's substantial, I'd only ask for brief questions or statements. Does anyone have a brief question or statement on these? Councillor Smith, please.
Thank you, Chairman. Excuse me. I note your request for them to be brief, so I shall endeavour to fulfil it. Whilst it's good to know, that the Lincolnshire system is on course to hit its target with respect to the percentage of agency staff, do we know of the 3.2% what that equates to in cash terms? And secondly, Chairman, with respect to the hard-to-fill roles that is mentioned in your announcements, I'm not surprised of any that are shown, especially with regard to dispensers, for example, and learning disability nurses, because obviously both are quite specialised, and one actually has quite a senior level of responsibility relative to their pay as well. It would be very interesting, Chairman, to know more about how they intend to fill these roles, and especially around the disability nurses, because I've not come across that role before, Chairman, so it'd be very interesting to know if we can a bit more about what they do. Thank you.
Simon, I'll bring you in.
Thank you, Chairman. I can make a note of those questions. We do have this item listed for the people strategy listed for January, but in advance of that, I can certainly ask the questions that have been raised. Thank you.
Thank you. Councillor Morgan.
Yeah, thank you. I've got 2 questions, if I may be as quick as possible. I'm just following up regarding the staff. I understand that as part of the acute service review at Grantham, there were supposed to be 8 substantive consultants on site, of which only 2 posts actually exist and the rest are locums, which is very concerning. My understanding is that there have been real attempts to recruit. However, the same pattern of recruitment's been used over and over and over again. So it's basically, can we understand what initiatives are possible for the recruitment and ideally retention of staff? For example, thinking outside the box and perhaps looking at Nottingham instead of just looking at them working Grantham and Lincoln, which apparently is not attracting the right people. if we could somehow put that forward and see what they say to that, if that's possible.
We've already got, as Simon's alluded to, people management coming to us in January, so it's an item we'll pick up there with them.
Thank you. And then the other one was about the GP, item 8, page 20, the collective action by general practitioners. I shared with you an announcement I received this morning, and I'm not clear if it's part of this or if it's something completely different, but we are being told that GPs across the county are going to stop doing dressings as of early October, which is hugely concerning. And I just wondered if you knew anything about that, or if it's something we could pursue, consider the impacts of that.
Yeah, certainly. We'll pick it up with Sarah Jane Mills. I know that not all surgery, I think, do dressings. I know that at my doctor's surgery, they certainly don't. And I think they contract it out. So it's the same with bloods. I think with my particular surgery, you have to go to the hospital and they don't deal with it, yet the neighbouring surgery do. So we'll find out contractually where that comes from and certainly pick up on it and come back to you directly.
Thank you.
No problem. Councillor Allen, please.
Thank you, Chairman. I'm just building on very briefly on, to a certain extent, questions that have already been raised. And my comments and questions are built against the background of likely new government initiatives about how they're going to address the waiting lists, which seems to be still growing, as part of their new strategy for the National Health Service. It's to do with the hard-to-fill vacancies. It does seem as though, it's been alluded to already, that the response that we've got in terms of how we're going to deal with hard-to-fill vacancies is to do the same as we've always been doing, which doesn't seem really to address the issue in terms of how we'd get hard-to-fill vacancies filled. So perhaps when we have the committee report in January, something can perhaps be some meat can perhaps be put to that about, you know, if we're failing to do it at the moment, what are we going to do new to actually address the issue? And secondly, again, perhaps an item for the report in January, if there is a possibility that 25% of the staff in our region is going to retire early, and may well be encouraged to retire early by various new financial strategies that might be coming out of the new government. That is quite a worrying figure, and the response that we've got so far in terms of how that's going to be addressed does seem to be fairly weak. So perhaps something more substantial can be put forward in terms of how we're going to deal with succession planning issues within our region of the National Health Service, in terms of ensuring that we don't end up with 25% staff disappearing from the workforce, with all the effects that's going to have on servicing the health requirements of our region.
Yeah, thank you, Councillor Allen. I think a lot of this really could do with being picked up in the work programme. I don't think it's necessarily under Chairman's announcements, to be fair, but we will pick up all those comments, and Simon certainly got them down. Do I have any other comments? Councillor Cleaver first, please.
Thank you, Mr. Chairman. A couple of things. Firstly, I noticed that there is a report, thank you, on the collective action by general practitioners. I have to say I was quite disappointed when a statement in support of that was placed on the website of my own GP practice. And when challenged, I was told that no action was being taken by the members of the practice. They just put the statement up in support, which I found very unhelpful to patients, let's put it that way. So may I, through you, urge the ICB to encourage practices to make it absolutely clear to their patients what action they are taking and what actions they're not taking in support of this. Thank you. And in terms of your statement about upcoming meetings, I would point out that the ICB is inviting patients and the public to its next board meeting, which takes place on 24th of September at 9:30. Thank you.
Thank you, Councillor Cleaver. We'll pick up on that. Thank you. Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. I was just a bit surprised to see on page 19 that the Lincolnshire Community Health Services are having their AGM this morning, which corresponds with this meeting. And I thought that was, if we're working in partnership, that was rather unfortunate.
to be fair with you, Councillor Atkinson-Saunders, I think there's often clashes with this meeting and meetings of the NHS. They do tend to happen a lot, which is why Councillor Woolley isn't here for most of these meetings. I think there's ICB ones on the particular day. So I think it's how it fits into their meeting schedule as much as anything. But I'm sure they can hear and listen to what's been said. Thank you. Any other comments now on the Chairman's announcements? No, in which case do I have a proposal we note them, please? Thank you, Councillor Wotton. Seconded, Councillor Hayes. All in favour, please show. Thank you. That's noted. In which case, we'll now move on to agenda item 5, the Cancer Care Programme. This item was circulated as part of the agenda pack on pages 29 to 63. The committee receives an update on an annual basis on the cancer programme and the Living with Cancer programme. So I'd like to welcome our presenters in person, Claire Raybould, Director for System Delivery, NHS Lincolnshire Integrated Care Board, Louise Jeans, Cancer Programme Director for NHS Lincolnshire Integrated Care Board, Lauren Rigby, Lead Cancer Nurse, United Lincolnshire's Hospital Trust, and online, Dr. Ciro Rinaldi, Director of Research and Innovation and Deputy Medical Director for ULHT, Maggie McManus, Deputy Chief Operating Officer for Cancer Care for ULHT, and Dr. Katie Massey, GP with Special Interest. I'll now hand over to our presenters, please, to run through for about 15 minutes, and we'll take questions at the end. Thank you.
Thank you very much. So I'm going to canter through the presentation. Will you share that then, Jess? Yeah. So just as you get that up, cancer still remains the top priority really for Lincolnshire and both the NHS. And the focus is still on that early diagnosis and that rapid treatment initiation. We're still working, if you move on a slide, thank you. We're still working to the long-term plan and the expectation is that within 55,000 people will be surviving cancer for 5 years post-diagnosis. And it's expected that 75% of cases will be diagnosed at the stages 1 and 2, which are the earlier 2 stages. The NHS, the government have tried to simplify the standards that we are now working towards, and there are 3 standards: the 28-day faster diagnosis standard, the 31-day standard, and the 62-day standard. That has reduced down from 10 standards down to 3. And really it's to try and improve and enhance safety for patients, improve their outcomes, improve their patient experience, and prioritise care for the sickest and most urgent patients. If you move on, thanks. The efforts in the past year have been still to reduce those backlogs and for improving those patients who get a diagnosis of cancer and then a treatment within 62 days. And this aligns with those NHS England targets. The progress exceeding expected trajectory, promising results in backlog reduction in efforts has improved. We achieved our target this year and we continue to drive down those backlogs to reduce those. The focus has been, though, for us on really the 28-day faster diagnosis standard, which may be an FDS in your pack, 62-day standard and 31-day benchmarks. We still have challenges across the system, fragile workforce, tired staff, burnout is key following the pandemic, and obviously the backlog clearance for both cancer and planned care. There are notable improvements for cancer pathways despite the challenges, demonstrating cancer care teams, dedication and enhancing the patient outcomes for Lincolnshire. Next slide, thank you. So this is the FDS, Faster Diagnosis Standard. This is one of the main standards that we follow. You will see a pleasing trajectory, I think, for the Faster Diagnosis Standard. And in June this year, we achieved our 77%. We're above and over trajectory now, and we remain over trajectory at the moment. The Faster Diagnosis Standard is about identification of cancer diagnosis for patients within 28 days, or those patients who don't have a cancer diagnosis are told that they don't, and they have moved off the pathway. So the improvements around that have focused on a number of pathways, and I'll go into that as I go forward. Next slide, thank you. 62-day performance, again, you'll see a pleasing trajectory. This is the most difficult standard to achieve, and there are around 4 things that we need to focus on to get this to a good place. 28-day standard, the 62-day backlog reduction, and the 31-day. And if you don't work on those 3 standards, then it does impact on this 62-day. But again, a pleasing trajectory in the sense that we're moving forward. It's slow and consistent, but we're trying to achieve that as we go forward. Next slide. 31-day is probably our weakest standard, and it's the area that we most need to continue to work towards. We are, the teams are working on it. The issue we've got is the fragility around workforce, oncology particularly, to try and capacity within surgical capacity. So these are some of the areas that we have, we recognise and that we're going to pick up and start to work forward towards for the end of the year. We are close to the standard at 96%, but it's not the trajectory that we would probably see it. You would see it's probably got a downward trajectory slightly. Next slide. So I think the commitment to the teams across the system, the collaborative approach that we have a dedicated team that works into ULHT to support these pathways and the staff. But we have an absolute, very collaborative working in the sense that the teams within ULHT are very keen to improve, and they see that the support from us across the system, so it is that collaborative approach. We're still active in our partnership with NWAFT, so North West Anglia and North Links and Gaul, and we still, although we don't have such a dedicated team that go in and work with them, we are very close to their improvements and what they're doing. And our focus has been on impactful initiatives and collaborative efforts that I've said already. Next slide. So this year we have, you'll be pleased to know that we've got a new programme of work called the Targeted Lung Health Check. This is a vital component of the national programme targeting individuals aged 55 to 74 with a heightened risk of lung cancer. Those patients will be, it's like a screening programme, so it's an addition to a screening programme. We expect that this programme will be up and running by the end of Q4 next year, but the objectives are really to try and identify those lung cancer patients earlier and identify the detection. Those patients will come forward for a CT scan, and that they will detect those issues early and hopefully potentially be put forward for effective treatment. Next slide, please. I'm going to skip through these gynae and the lung cancer pathway slides. There's a lot of work going on. It's all in your packs, but basically we've the 2 areas that we've looked at from a gynae and lung is that we've identified issues, particularly around capacity. We've used we've used East Midlands Cancer Alliance monies to support new posts within these 2 pathways, but basically they are now doing really well from a process, and they're impacting on those performance metrics. If you skip along to the next one as well, please. So improvements. We've refined, as I said, the gynae pathways. We're improving the treatment aspects of the colorectal pathway, and we continue to do that. We implemented the FIT pathway a number of years ago. We're identifying and addressing bottlenecks this year with the urology pathway, looking at the front end of the pathway. We're developing a teledermatology pathway, which is a skin pathway, and we've got commitment to improving cancer for an unknown primary service, which is the CUP, Cancer of an Unknown Primary CUP service. The impact is that it was sustaining and improving performance, and that's a iterative process. We're tackling potential health disparities. We're embracing technological advancements where available, and we're advancing cancer care in the county. We continue to have challenges and risks. Those resource constraints impacting timely delivery for cancer care services, the waiting times for diagnosis and treatment, and they're part of the work that we continue to do. Staff shortages leading to treatment delays and psychological distress. Need for patients to leave Lincolnshire for diagnostics and treatment. Some of our areas, we don't provide all of our services in Lincolnshire, and therefore they go to our other surrounding services such as NUH. Geographic disparities in rural areas of Lincolnshire. You'll know that our road networks are not good, and it's very difficult for our patients to travel across the counties. Limited access to specialised services and care coordination challenges. Importance of patients' awareness and engagement in cancer care. Barriers to such as a lack of awareness of health literacy. Collaborative efforts needed to address challenges in those cancer care delivery. And I'm then going to move on to the Living with Cancer programme. So this is a programme that looks at the patients who have had treatment and are now living with the disease. So we have increased our holistic needs assessment, which is an assessment that is done in ULHT for patients. All patients are offered a health needs assessment within 31 days of diagnosis, and we've improved this from 41% to 49% from September last year to this year in June. Although that doesn't seem a huge amount, it is a huge achievement within the Trust, and we're really pleased with that effort, and that continues to improve. The personalised stratified follow-up pathways are now being operationalised in ULHT for both breast, prostate, colorectal and endometrial, and there will be further pathways to follow up at the end of this year. We have 61 out of 82 practices who've accessed the cancer care review training, and that's to support patients in the primary practice once they've come out that they have a cancer care review to consider their unmet needs once they're out in once they're living with the disease. 307 patients support requests have been actioned. We have an email inbox, and that email inbox can be accessed from all health and social care individuals to refer in, and we can pick those up. There are test projects ongoing for information, advice and support hubs within Mablethorpe, Lincoln, Birchwood, Gainsborough, Skegness, Boston and Spalding, and that's a big achievement for this year. We've got a huge achievement and a collaboration with Anglian Water, and it's enabled 5,000, just over 5,000 priority service registrations, and within that over 25,000 assessments being offered to access to patients who suffer with income issues, debt management, payment breaks, bill reductions. This is a massive collaboration across the system, and we're also looking to do this potentially within the electric, obviously Anglian Water, but we've had conversations with electric companies as well. 252 patients were referred to Fighting Fit, and that is across that is not just in Lincoln, it's in Boston, Mablethorpe, Skegness and Gainsborough. We've received a number of awards this year. The biggest award was the Eric Watts Award for Excellent in Patient Care. We've been shortlisted for a digital award, which we didn't receive, but we were shortlisted, and we've had a number of national and regional, international presentations. Last year in the report, Chairman, you asked for to pick up the issues of support for families and the work to support other comorbidities. The team have been working tirelessly to support a number of areas, but children and young people affected with a family member who have had a cancer. And they've been working with the, I can't see it, but the Tiny Steps Petting Farm, which is down in Bourne, providing support to children who have a relative who is suffering with cancer, and that is ongoing. That's a new piece of work. We've also included support for wider families as well, and families now have access to level 4 psychological support, it is new. Next slide. The comorbidities work. We are now transitioning this team, which is a small team, and we're hoping to transition this team into a Living Well team. And that is a team that will look at using the framework that we've done in the Living With team, but lift and shift that into other long-term conditions. And that will become the Living Well team. And we're testing that at the moment around the respiratory pathway, looking at 8 conditions within that respiratory pathway that are listed on screen. Future work, next slide. So the transition for the Living With team is to move into that Living Well programme Evolve and roll out the support for workplaces and pharmacies. This is a new piece of work that we'll be picking up. We've been picking up this year, but it's a priority for us going forward. Identify opportunities for volunteer peer support and community champion projects. Support for patients treated out of county, actively engaging with other trusts such as North West Anglia and North Links, to ensure that patients are treated out of county have access to those community supports once they come back in, and voluntary services at their home communities. And also identifying the next steps for health and wellbeing focus. Next slide. So in conclusion, a little bit over time, apologies. Transition for the Living With team and the Living Well programme to significant improvements within the cancer performance, which I hope you recognise today. Commendable effort from all those healthcare professionals and the teams across the system. Acknowledgement for remaining work to be done, particularly around 31 day, and continuing with the trajectories that we're on. Ongoing challenges requiring collaborative working and that collaborative approach that we've managed to achieve. Collective effort and shared responsibility key to enhancing care quality. Focus on continuous improvement and patient experience and outcomes, and setting a benchmark for exemplary cancer care and patient support. And that's the end of my report. Many thanks.
Thank you for an incredibly thorough report. We've now got questions, so I'll start with Councillor Parkin, please.
Thank you. Can I just say it's really good to hear what you're saying in terms of supporting families, particularly young people, with cancer in the family. I think it's really important that we have that holistic view. Please excuse me, Chairman, if I'm talking about personal experience, but I think it's relevant in terms of what we're talking about in terms of trying to understand where the problems are within the system. And can I just say, I do have permission from these people to talk about this. Very close family relatives, one who has been diagnosed with skin cancer in the last few months. Very rapid diagnosis from the GP and then referral on, very quickly seen, and then not the best news ever, but a good idea of treatment and moving forward, and a good, a good outcome. So everything that you would have expected to happen happened. On the other hand, 80-year-old with consistent UTIs, COVID, big health collapse, and then repeated difficulties with liver function tests, which matched what you would expect in terms of the other bits and pieces that were going on, but nonetheless was fast-tracked for scan because there were lots of anomalies in that particular test. So week and a half to the scan, everybody's heart in mouth, wondering exactly what was going on, and then nothing in terms of results. And I think it was the GP who finally chased those scan results up, and that was really difficult, because although you think you can explain what has gone before, you suddenly have this seed of doubt. Well, we had to have, scanning so quickly, so they must be worried about something. And then, honestly, it felt horrible when things were then lost and all the rest of it. And it did definitely increase the trauma of the whole thing. It was a horrible time anyway, but it was made worse by that. And so it seemed to me that where you've got somebody who was on a definite cancer pathway in terms of the skin cancer, it was clear this was cancer, everything seemed to work really, really well. But when you'd got somebody, and I don't know if this is reflective of the pressures within the system, when you'd got somebody who was presenting with multiple challenges, and there was the question mark of cancer, which the family weren't necessarily thinking themselves because there was so much, but then suddenly lost in the system. And I do wonder if other people who are having those tests and then having those scans, where people aren't actually clear what pathway they are on, and Was it the frailty team? Was it the GP? Was it somebody from your side who I don't know. And it was really difficult. And if that's being replicated a lot, there's going to be a lot of very anxious and stressed people around the county.
Thank you. And powerful stories, so I recognise that. We don't get it right all the time, which is, you know, and there's many patients that go through this. I think what I can reassure you with is that through the acute phase of that pathway, those patients should be supported by a navigation team. And once a diagnosis is achieved, we also have a cancer care coordinator team alongside the specialist nurses of whatever specialty they're within to support them. If that doesn't happen, then I'm happy to pick it up and flag it offline to ensure that we do that. So I'm very happy to do that. But as I say, though, we have those navigators and the cancer care coordinators who try and support those patients through that journey to ensure that they turn up for tests, that they come at the times that they're happy to. We have quite a lot of patients that are nervous to come in still. And that impacts massively on our pathways and the times. So, but again, if I can reassure you in any way that we try and get it right as much as we can, but ultimately the navigation team are there to support those patients.
Thank you, Chairman, for letting me come back. I think I'd love a chat afterwards if that's okay. I just think that patients need to know who is responsible for what and when, and then have that kind of accountability to some, you know, to know that there's somebody who's going to be accountable. And I think that's the problem, is when you fall through the gaps, it just makes the whole process so much more difficult.
Thanks. I just wanted to add that one of the pieces of work that Louise mentioned was cancer of unknown primary, and quite often we don't know, so they're not on a specific pathway, so they won't have an accountable person other than the GP that's referred them whilst they're in that space. So that's why we're picking up that work on cancer of unknown primary, because quite often, and it does tend to be quite, particularly with elderly people, it is quite difficult to work out what it is that, or what it could potentially be. So that work will help that. So we do recognise that that's something that would help in Lincolnshire.
Dr. Ronaldo, you'd like to come in?
Thanks, Chair, and very powerful story. And I just wanted to, apologise that the process has not worked well. And I think I would have to agree that when the cancer pathway is clear, I think we do better. When there is a referral for query cancer, within our ULHT wards, perhaps the process needs improving. I think it would be helpful to understand what actually happened in this particular case. I have some possible explanation why results are not being flagged, etc. So there are processes that needs to be made more consistent. But I think we do see a bit of discrepancy when there is a clear pathway and all the support around it, cancer navigators and a team that is flagging results. Things were better is when we are in a grey area territory where there is a suspicious, the scan might have been requested in the appropriate manner. So there are pathways that we follow within the diagnostic. So there can be many reasons why that didn't happen. It's not an excuse. It's just to sort of highlight that we are aware of those problems. And is how we make that more robust, particularly when there is a suspicious. And then is the communication of what is happening that we need to make better as well, to explain why we request what we request, what we're waiting for, and who is leading on that diagnostic. And sometimes when patients move from one area to another area, there is a little bit of gaps in between, which we are working on. So very happy to have a separate conversation as well, if that helps.
Okay, thank you. I've got Councillor Allen next.
Thank you, Chairman. It was a very good presentation and contained an awful lot of useful information. And I don't want to, my comments are not meant to denigrate anything that's taking place in terms of this important work. The question I've got, Chairman, is there seems to be a lot of local initiatives taking place in terms of cancer care, and a lot of attention being placed on the targets and statistics. But what concerns me is that the NHS, and this is the issue, that it's National Health Service as opposed to Lincolnshire. The National Health Service record in terms of cancer outcomes is not very good as a whole, and I think we are fairly close to the bottom of the European leagues. So what I'm not sure of is whether these things are aimed to simply keep us at that position and stop us falling any further, or whether these are actually being considered to improve the situation, or at least the situation within Lincolnshire, and how that fits into the national picture. But my real concern is that what is happening nationally in terms of addressing that issue, because all we seem to be doing at the moment is trying to keep our position at the bottom, towards the bottom of the European League, and that shouldn't really be what we're aiming for. We should be aiming to improve the situation where we are, not simply keep the position that we are.
Yeah, thank you. Recognise that the position where we're within the National League, and I'm not going to comment on that necessarily, but I do understand that if we can get patients diagnosed in that timely manner, and that diagnosis is at that earlier stage, and if I come back to my first slide, I think it suggested around staging that we get by 2028 we have more patients diagnosed at stages 1 or 2. The outcomes for patients will be better because they will survive the cancer, they will survive the disease. At the moment, our patient staging is around the 3. Can slip to the 3 and 4, and therefore the staging, that staging is then more difficult to survive. So I think our aim and the attention is to get those patients diagnosed within 28 days, and treated within the 62-day to ensure that they have the best optimal time to survive, basically.
Thank you, Chair, for your leniency. I appreciate that. But is all that going to do is keep us at the current position in the table, in the international league tables? Or is it going to actually start moving us to where we should be, which is presumably where the National Health wants us, towards the top of that, to show that the NHS is actually producing the goods and is one of the best national health services in the world, which is what we keep on being told. But the statistics nationally, internationally don't suggest that is the case.
My understanding would be that the statistics that we're trying to work towards will have an impact on improving that position. But I can't really comment on that position. Locally, we have to do our bit to fit into that national picture.
I mean, a question for you.
Right.
We always end up with this issue of what happens locally as opposed to what the targets are nationally for a National Health Service. And we don't seem to be able to get answers, to the national situation. Locally, we understand what they're trying, what is happening, and what the local professionals are trying to achieve. I'm still not totally sure whether these are national initiatives that have been rolled out locally, or simply local issues that have been rolled out in the absence of anything coming nationally. So I find it very hard to understand, because if we can't actually deal with the national picture, how can we work out how we're actually operating locally for what is supposed to be this National Health Service? Is there any way that we can actually get hold of National Health Service England, or whatever it is, whoever is responsible for the national targets, and talk to them as well?
I'll bring Claire in, but I think you'll find that it is based nationally anyway, and it will be through what NHS England are obviously pushing down to look at having done locally, because they do work in conjunction. But I'll bring Claire in.
Yeah, thank you. I think what Louise has tried to explain is our position, because that's what we're responsible for. And we do benchmark in terms of the NHS. We don't benchmark in terms of Europe, if that makes sense. But just to clarify, everything we do is within the national framework. So it's the NHS national plan, it's the long-term plan, their strategy for cancer services, and all of that. So the targeted lung health check, for example, everything's a national programme. What we're describing is where we are in Lincolnshire against those standards, which are designed to do exactly what you've said, but they're not. It's not explicitly said in the national documents. But when you read the long-term plan, it talks about how it's designed to improve staging, for example, which will improve outcomes, which will bring us up the league table. But obviously, for our purposes, we're concentrating on the Lincolnshire residents, but it is part of the national plan, so hopefully that helps assure you.
Thank you, Councillor Anna. We will make sure, of course, when we bring any papers forward again in the future, that we'll try and get more information actually directly from NHS England on what their targets are. But I think, you know, the right thing is that we do want to be concentrating on locally first, because we need to solve the problem that's actually directly affecting our residents. But thank you. I've got Councillor Smith next, please.
Thank you, Chairman. I note the improvements that have taken place, and everyone involved in those are to be commended, because I know generally in the NHS it's a difficult environment, but especially in the environment where cancer care is concerned. And my question is, given the numerous hard to recruit roles in the cancer field, what is the assessment for those roles being filled so that there are no shortages of roles in terms of staff? And secondly, of the staff in those roles that are already in place, how many of them are coming up to retirement?
I'll come in first. So I don't have the actual numbers for all of our providers to hand, but we can certainly look at that. And I would say that links to your people strategy as well that you've got coming forward. So you know, it is really challenging. There are some really difficult roles to fill. We do be quite innovative about that, but the further east you go in the country, and when you're not a big teaching hospital, that does make it more difficult. People are attracted to the bigger cities and to the big teaching hospitals, and you'll know that we're trying to address that through other means. Where we do attract them, we do retain them, so that is really positive. And we've got a great experience for people working in Lincolnshire. So we continue to do everything that we possibly can, but there are some areas Louise talked about earlier, oncology, it's quite difficult. And where it's a nationally difficult place to recruit, it's equally a problem in Lincolnshire. But I don't know whether Chiro or anyone else wants to, or Lauren, you want to add anything?
Yeah, Dr. Rinaldi, you'd like to come in?
Yeah, so I totally agree with the challenge that has been highlighted. You know, clearly workforce has been a problem for many years, not just in Lincolnshire. You know, there are fragile services. Hematology, oncology, for example, has been fragile for a while, and not just in Lincolnshire, is a regional and national issue. There's been a process set out recently to, you know, highlight the level of support and the conversation for fragile services. But I was going to say that there's been some, you know, good story, you know, very recently, and I'm talking about probably the last year or so, where we've been able to attract more people in historically difficult jobs. I'll just give an example, you know, just for the hematology service in Boston, where I used to be the only hematologist for the last 10 years, pretty much, with locum coming in and out. We are now 4. So there's been a significant increment in number of appointments, and that is a result of, you know, team working, but also, you know, the way to sort of change the culture around Lincolnshire. You know, you can come in and actually do what your career development wants to be. So I think there is a green shoot at the end of all of this, and it remains under scrutiny. So and to answer the second part of the question, which is, you know, some of those jobs are very targeted around the area where we are not able to, you know, fill gaps. Oncology is a bit more problematic, because oncologist needs to be more specialized. You know, different oncologists do different type of tumor site. And that has been more challenging compared with hematology, where we can cross cover, for example. But even in oncology, there's been some success. And the teaching hospital status and the work that we're doing around the university hospital will help. You know, there's been a lot of discussion with University of Lincoln about creating a pool of joint academics, so people that will come in and do part clinical work, part research and teaching, and that will help attracting, so we'll be more competitive in the national map. But it was just to say that, you know, we are constantly working on that. Our trust level, our ICB level, and I think we're seeing some successes. To a point, the NHSC wanted to use our case, you know, to probably explain how we were successful in some of it. We just please watch the space.
Thank you for that. And whilst not necessarily relevant to this specific paper, Chairman, I think it's relevant to a wider issue that if we could pick up would be helpful around where we are around the possibility of getting teaching hospital status, because I know it's been reviewed and been trying to be done for a long period of time. It's not going to be a magic bullet, Chairman, nothing is, but it will be a huge help. It will be absolutely massive. When Nottingham got it a number of years ago, it was all, the takeoff from that was almost instantaneous of the number of graduates they had, and because they were in Nottingham already when they were training, they didn't want to leave because they were already there, they'd put roots down, they had their families, and it would be a huge help, because certainly the perception, and it's not just the National Health Service, it's the same in the police as well. The perception is you come to Lincolnshire towards the end of your career to have a bit of a quieter time of things, shall I say, than at the start of your career, and we really need, as much as we can help the ICB and colleagues, to sort of shift that perception and say, actually, come to Lincolnshire at the start of your career, because actually it's really good, it's really interesting, it's a really good place to work, and having a teaching hospital would help that. So I don't know if that's something we can pick up, Chairman.
Yeah, I think we've already supported it quite substantially, and we've chased it a few times. I think the ICB and everyone else involved are probably desperate to find out that they've got that status and finally get moving on, because you're absolutely right. It will be very helpful. Dr. Rinaldi, you'd like to come back in as well. Thank you.
So yeah, a bit of an update about the teaching hospital status. So at this point, you know, we've been just waiting for the final sign-off from the Minister of State, Karen Smith, who had the application for teaching hospitals, and I believe that this week was the week for the sign-off. So once we get that confirmed, the board will go through the process of, you know, our internal engagement to change the name, etc. So it's absolutely imminent. And that, as you said, will make a huge difference in the way that we can attract people. So it's happening between this week and next week.
Thank you very much. I've now got Councillor Geeney, please.
Thank you, Chairman. First of all, those slides we saw, I know they contain a lot of the information that is in the papers, but in a pre-seed form. I wonder if they could be made available, because they are a little bit easier to pick up specific points on if we could have them. That's the first question.
They're in the paper, as far as I'm aware, that went out. They're already in the pack, but we make sure that we can send them separately anyway.
Yeah, I think they're in the pack.
They are in the pack.
The slides looked a little more of a précis. I was trying to see if they matched, and they seemed a little more précis than the full pack did.
We'll certainly send them out separately anyway, because we do have the pack we can just send over, so that's not a problem, Councillor Geeney.
Thank you. The other question is, it was stated that they're doing lung cancer checks from age 55 to 74. I wondered what the basis was for, well, 55 maybe, but for why stop at 74? Is that an age after which it's unlikely people would get lung cancer, or is there some other rationale? Thank you.
Yeah, it's the national screening programme age that indicates. The only at the moment with bowel is that we're reducing that age down. It may be that the lung cancer also will reduce to 50, but it's 50 to 74, which is the screening programme.
I was more wondering why 74 was the cut-off mark.
Yeah, but it's just set nationally, so we can take that away. But I get there will be an evidence base for it, I'm sure. But it is just set as part of national screening programmes. We don't have any control to change that.
No, but I think if you can get any feedback, it'd be useful. Thank you, because it's a fair question, certainly. I've got Councillor Haigh next, please.
Thank you. A lot of questions have been answered up to now. I've had blood cancer. I've had non-Hodgkin's lymphoma 4 times, and in the early 2000s, I chaired the Cancer Patient and Carers Forum. I did it for over 5 years, and so I'm going back. You know, your 2-week wait now. You've got other procedures in place, but your 31 for scans and 62 for treatment is still ongoing. And over the years, to me, the figures don't seem to have moved that much. Catch up, you know, trying to catch up all the time. And it's very good that you've got your faster diagnosis of 28 days. That's brilliant. But I am concerned that nothing seems to, you've gone fluctuated a bit. I know we've had COVID and different things, but you're still on this sort of catch up. And also, I'm wondering if that is to do with staffing issues and expertise that you need to get into the county. And my second question is, you said 252 patients have been referred to the Fighting Fit. Can you just explain a little bit more about that as well?
So we are still on a recovery trajectory following COVID, and that is why our we've been working initially on the backlog to reduce those patients waiting over 62 days, and that's been the biggest area of work that we've had the impact on. That has now reduced down to an acceptable level, and we're still currently trying to pull that back down. And so that recovery has been from COVID, and although that's no excuse, that's what the indicator is, and that's why we've been having to work. And apart from 31 day, I'm very pleased with the way that our trajectories are looking for our 28 and 62 day, because that is often getting patients who are diagnosed quickly and then treated within that time frame. So I think the indicator for that was COVID, and we're still recovering from the backlog. And your second question was about Fighting Fit, is that correct? So Fighting Fit, we collaborated with the Lincoln City Foundation Football Club, and I'm no football fan, so if I got that wrong, I apologise. So we've collaborated with that team, and they have now, because there is so much evidence around exercise during treatment and following treatment, we have collaborated with them to provide exercise classes, free exercise classes across the Lincolnshire. And so we first started in Lincoln, and we've expanded out with the Lincoln City Foundation charity, and they now provide these these Fighting Fit classes across the county, which is providing patients can volunteer to go, they can sign up. There's I think they go for an 8-week, 12-week course, and they get a lot of benefit out of it.
Just ask another question. Well, it's a comment, really. You're saying that you want more people to come forward that stay earlier, stages 1 and 2. But, you know, it's getting people to go to the GP in the first place, which impacts on what stage they get to you, because a lot of people hold back, don't they? And then they come back, and then they're at stages 3 and 4. So is there any, I don't know, advertising or anything on, you know, to encourage people to come back, you know, forward quicker?
So there will be national programmes. So we had the BOWL programme. So the screening programmes are those programmes that we would try and encourage those patients to understand their symptoms of whether it's lumps in the breast, you know, understanding whether you've got blood in your stools. So there are national programmes out there that support, and when they're launched, we then relaunch them locally. But we haven't actually done any local initiations. I suppose for me, it's the preventative measures that we're trying to understand. So, you know, keep well, keep fit, keep healthy. Don't drink too much alcohol. Make sure you've got, you know, you're taking exercise. All those preventative measures that we take, but encouraging people to recognise those signs and symptoms and go to their GP and act on them quickly is massive issues. And then once they come into that, then they've got to come in and go through quite a traumatic journey once they're getting a cancer diagnosis.
Right, thank you.
Thank you. Councillor Geeney, just coming back to your question, Dr. Rinaldi's actually commented in the Teams app that it's for surgical reasons. He believes that it's the age of 74, but he'll definitely check for certain. And Katie, I understand you'd like to come in as well.
Yes, thank you for that. Just coming back onto the targeted lung health check, it's 74 and 364 days. And I think when NHS England looked at the evidence behind early detection, this was the age group that would benefit most from it. And some of those reasons, I think, will be regards to surgical treatment. And I think as the programme develops, maybe those age ranges may change. But at the moment, that's what they are stipulating should be the age that we target.
Thank you very much. I've now got Councillor Burke, please.
Thanks very much, Chair. And thanks for the very detailed report as well. So much stuff in there. If I could just begin, Councillor Smith made me think about relationships in terms of recruitment. So I'd like to ask you what your relationship is like with the University of Lincoln Medical School, whether or not there is anything to be gained there. I picked up in your verbal report issues around geography and also people going out of county. Are you liaising, or should somebody on your behalf be liaising with people like developing highways policy within Lincolnshire, which is a county council responsibility? You know, are we putting the issues, the concerns you raise about patients getting around the county into the people whose job it is to fix that? Although they'd probably argue they haven't got the resources, but I think there's a liaison there. In terms of, I just wanted to mention as well, in terms of page 35, where you talk about targeted lung health checks. My own surgery, the Heath surgery, through the pharmacy, and I'll come back to pharmacies in a minute, picked up that I had some issues, and there were rapid scans to ensure there wasn't a cancer diagnosis. So there's stuff going on at that level, which I thought I'd just share. Page 42, pharmacies. So I've recently had some discussions, almost by accident, with the new chief executive of the co-op. So I was very interested because you mentioned the co-ops, and I'd be interested in the detail of progress, if that's appropriate, that you're making there, because I know one of the success stories within Lincolnshire is the co-op retail movement, and I get the impression there are considerable plans for the development of pharmacies by the co-op. So I think I've covered everything. Thank you.
Okay, so probably myself and Cherry can pick up the first part, and then I might defer to others. But the first, so I have two hats. I lead on the Clinical and Care Directorate work too, which sits under Sunil Hindosha, our medical director, and we sit in the medical school. So I work from the medical school, and our links within the medical school. And Cherry may be able to come in on this a bit more. We completely, so the research teams within the medical school are now linked to both cancer and other areas of within the ICB, and we're focused on collaborating with the university to do that. So just to give you some reassurance around that medical school and the work that we're trying to do. I don't know whether Chiro's got his hand up at all. No, he hasn't. And then I can pick. You're going to pick up the co-op.
He's got his hand up now.
Oh, has he?
That's all, ring him in, thank you.
Sorry, so sorry. Yeah, so absolutely, medical school is a key part of our recruitment strategy, which is probably one of the reasons why the school was approved for Lincolnshire in the first place. This year, we graduated the first group of medical students, which are now going to move into postgraduate training. and we are in the process of getting University of Lincoln independent from Nottingham, meaning that we then can work on the postgraduate course. And this year we had the appointment of the Dean of Medicine. So all of this is working towards that plan. And I just wanted to probably remind that, the School of Nursing, for example, which obviously was earlier than the medical school, has been also a successful story for recruitment of nurses, which perhaps Lauren wants to expand a little bit on. But that is really key. And the integration between the stakeholders within the ICB, focus on recruitment on that area. In the next few years, I think there is an expansion plan regarding the number of medical students that will go through. Some of them might follow the route of apprenticeship. So it's going to increase number of students, meaning that we will have more doctors. It's not a short solution. It's not a quick solution to the problem, but it's definitely the long-term plan.
Am I still on? Sorry, I'm still on. And then your out-of-county question. So yes, we do recognise that the networks across the road networks across Lincolnshire are difficult. If you live on the East Coast and you have to come to Lincoln County for your oncology, it takes you an hour and a half. If you don't have a car, you have to get on several buses. And if you then have to go across to Nottingham, it's even further. So we recognise that that's an issue. I think what we are trying to do around our CDCs, so our community diagnostic centres, are around looking to place those around the county so that they are closer to the patients in those more rural, difficult areas to access through road networks. And they both look at diagnostics, and we're venturing into some treatments being delivered there within diagnostics, within the CDCs. So oncological treatments could be potentially looked to be delivered within the CDCs. So that's trying to combat some of those areas of rurality around our system, if that helps. Do you want to add anything?
Yeah, thank you. And just on the co-op, so our Chief Executive of the Integrated Care Board has recently met with the Chief Executive of the co-op for Lincolnshire, and we've just agreed a strategic partnership really around what we could do more with co-op, not just in terms of the pharmacy, but their premises throughout Lincolnshire, whether it's the local shop that you're going to buy your bread and milk from or the pharmacy. So it will incorporate what you've said, really. I think there is huge opportunity for us to do more, and we're just in the early stages of that and doing some scoping work with some of their senior team. The bit in the pack is specifically linked to the Living with Cancer programme, where they're doing some work with existing premises, so existing pharmacies, to understand what they could do and how they could help support the programme.
If it's brief, I've just got 3 more speakers still to come in yet, and the item is meant to finish for about 5 minutes.
I just have an outstanding question. I mean, thank you for all those very detailed questions. And this may not be a question for you, but somewhere in the mix, there should be the needs of the NHS talking to highways about the future development of highways, because clearly highways is failing, and that's not necessarily highways' fault, because we're talking about a long historical problem. But when roads are planned, and we have this blurry, joined-up thinking idea, everybody should, I think, be in the mix. And it's clear to me that the points you're making really should be looked at by the road network planners. So that's just my point. Thank you.
Thank you. Okay, I've got Councillor Morgan next, please.
Thank you. First of all, if I can ask a bit more about the Macmillan Outreach Project. Representing South Kesteven, I can't help but note that none of the sites actually are in our district, which is disappointing, really. And I'm just wondering, when you talk about test projects, so that's encouraging, implies growth, and that you might be expanding. Can you advise when, how these are going, and when you will be looking to increase the sites so that the south of the west of the district, west of the county, is actually covered, and ideally including Grantham, given the size of the town? That's the first question. The next one was around the we've identified already that Lincolnshire's got a higher than average rate of cancer when you look across the country. Do we have any research? I know you're probably so busy firefighting, you haven't perhaps got time to do it, but have we got any research to indicate what the causes are? Why is our county particularly different to the rest of the country? And then have we thought, this slightly touches on the planning point re-highways that was made, given that, do we get as a county additional resources specifically for cancer treatment and support because of that from the government?
So if I can pick up the first question, and I'm going to phone a friend and ask Chiro to come in if that's okay on the second question. So the information advice and support hubs, which I think you're relating to, are in Mablethorpe, Lincoln, Gainsborough, Skeg, Boston and Spalding at the moment, and they were purely done around the areas of higher deprivation, which is where we started, and there was a greater need from those patients that indicated that they needed, but we do recognise that that doesn't cover across the whole of Lincolnshire, and that isn't to say that we're not going to go into those other areas, more affluent areas, but that we just need a plan to do that, and it's just time.
May I just come back on that? Because actually there are pockets of severe deprivation in Grantham, some of the worst in the country. So I would just like to make that point, if I may, on that.
Yeah, thank you. I recognise that point. Probably affluence, they're not right, the word to use, but ultimately we've been to the patients to ask them what they wanted, and these are the patients that came back to us to indicate that they needed advice support within these initial areas that we started. Not to say that, again, we're not going to be taking it further.
Okay, thank you. Did Dr. Rinaldi want to come in on that any further?
It was on the second point, I think, on the rate of cancers. Chiro, can you help out with that?
I don't think we have research intelligence around rates of cancer, etc. I think we do have information about staging, so rather than incidents, more about how do they present. And it links where what we discussed before around late presentation and why. And I think the logistics that we highlighted before, particularly not going to GP or not be aware of some of those symptoms, play an important role, and area of deprivation where apart from access to medical care, there is also understanding of what to look for as an impact. So it's a combination of points that are extremely vital, which is why it's important that we reach out to those communities even more. And then there is a different piece that we've done some work within the RNI regarding some of the diversity element that play into that. How do we reach out on specific community and how do we match with their expectation of how do we examine them, how do you talk to them about some of those issues, etc. So it's very complex. I don't think I have a specific answer. I'm just trying to explain that we are aware and we understand the complexity, which doesn't have a simple answer, unfortunately. But some of those planning in process will help some of it.
Thank you. Really quick, it's just a comment. I notice all of the graphs talk about percentages. Can we please have some actual figures in there? Because I think it will show how much work you're actually doing, but also the scale of the task. I hate it when you only see percentages. Thank you.
We'll pick that up on the next time that we have the paper come forward, and I would ask that if you've come back once, please don't come back a second time. Councillor Cleaver, please.
Thank you, Mr. Chairman. I think we're all conscious of the degree to which there's a lot of publicity going around to encourage people to get screened, and particularly for men's health. You can't get away from it. It's everywhere. And so I'm quite surprised not to see the emphasis on screening quite so much appearing in the report. So I'd welcome your comments on that. And I wonder if you'd also like to comment on the role of GPs in encouraging people to be screened, and how well that works. Obviously, you've made reference to the fact that these are often national schemes. And I wonder whether you actually have any figures on whether participation rates in those national schemes and participation rates in screening generally are higher or lower within Lincolnshire, because I think that's an important thing to look at. Again, just to emphasise the fact that you've said that early identification is really important. So I would expect to see a little bit more in terms of in the report about encouraging people to do that, and how we make sure that that is happening, it's monitored, that we know that it's successful. So I would appreciate your comments on that. Thank you.
I'll come in first. So thank you, really helpful observation. And the screening programmes are responsibility of NHS England rather than Lincolnshire ICB. That's not to say that we're not interested, and we do review them at our cancer programme board. So so it's a fair comment, and we'd be happy to, when we do the report next, to invite NHS England colleagues to come with us and do an update on screening. I think it's fair to say it's quite mixed in terms of uptake on screening, and the further east you go, the uptake is lower, and that kind of links to what you've heard in terms of where we do some of our targeted work. So through our health inequalities work as an ICB, it is something that we're picking up, and what do we need to do in a targeted way with those communities, because some of these people won't be presenting at the GP, so we do work with the GP practices as well, but it's how do we work with the individual patients, a bit similar to we did, you'll recall, during COVID with the vaccination programme, where we did some very targeted work with at-risk vulnerable groups. We need to be doing the same through screening, and screening will in the future be coming into ICB responsibility from NHS England. So we're starting that kind of, what do we need to do with them ahead of that, but very happy to ask them to come with us next time if that would be helpful.
Thank you. I've got Councillor Kendrick, please.
Thanks, Chairman. I think actually the questions I was going to ask have been actually answered previously. One of them was about the faster diagnostic standard of 77%. I was just intrigued to know why 77 was chosen, not 75 or 80, but I bet that's not really within the remit of colleagues here to answer that one, because it's a national standard. The other one was, and it's been discussed earlier, the lung screening programme. I was just wondering how people are identified for it. Is it an automatic referral, or is it something that's shown on the evidence of their medical record that they should get screening? I'm not quite sure how that's done.
Just going on the FDS standard is set nationally. It was 75% for us to achieve this year. I think it'll rise to 80% next year. We've achieved 77 this year so far, so that's where we're at. The lung pathway, my understanding is if you've ever smoked, and I'm just going to bring Katie in because I think she'll have that level of detail, but it's patients who have smoked or over 100 cigarettes, I think, but if Katie's there, I'll bring her in.
Thank you for the question. Thank you, Louise. Yes, so it's patients within the age range that has been detailed who have ever smoked 100 or more cigarettes in their lifetime will be called or invited for a lung health check. They then will be triaged according to 2 risk calculators as to whether they go further in that process or whether they're deemed low risk.
Thank you. I've got Councillor Mackinson-Saunders next.
Thank you, Mr. Chairman. Well, I think we all accept that rural communities do present a challenge for cancer, because I do know people turn up late and all the rest of it. I sit through these presentations and do get a bit frustrated because I don't know, in north of East Lindsey, we tend to get sent up to Grimsby, and I don't know how these standards compare with what people are getting over in Grimsby and stuff, but I don't know how anybody decides if you're going to Lincoln or to Grimsby, and I don't think any of us do, and we don't grasp that, and those are really important. And I didn't know if your 31 days were working days or if they're days, because when you're poorly, 31 working days is a damn sight longer than 31 days, full stop, isn't it? But to go back to the children and families and how they cope. During the summer holidays, I've been feeding young carers, and we've had a vast array of different people coming in, And I've come across quite a few families that would probably would get some help from one of the schemes you're talking about. But I don't know how we access those, because if you don't know they exist, you don't know they exist, do you? I can think of one chap who's obviously had his voice box out, who has to talk through a little thing on his throat, and his child one of his children is a 4-year-old who's autistic and can't talk. He can't go on the phone to talk to anybody, and it's, you know, you pick up all these things when you're out in the community, which you probably don't pick up where you are in quite the same way. But so I think communications is a huge challenge. I do admire the dementia groups, because they have got their message out, and they do have lots of groups who, you know, they meet, they share information. And I just wondered if we could, you know, if there could be living with cancer groups, which could be set up in a similar sort of way. And now older people aren't going to get their money for winter heating. They're all going to be needing to get a little bit of extra money, because if you're a cancer victim, you need to be warm in the winter, don't you? So I do think there's some gaps that we might be able to fill through those of us who volunteer quite a lot in the community. And you've got to start throwing the information at people like me, so that we can pass it on and signpost people. But it is frustrating when you live in our bit of Lincolnshire and you go to Grimsby, and we have no clue what their standards are or anything. But well done for what you're doing in Lincolnshire, because my mother had advantage from you, but I don't know where we'd be sent to these days.
I live in the Louth area too, so I understand. So 31 days is 31 days, it's not working days. So, and 62 is the same, 28 is the same. The ICB standards, the Macmillan InReach service that we're talking about, I don't know, Lauren, do you want to just...
Yeah, I was just going to say, so the Macmillan Outreach Service, that's part of their scope. They're trying to find out how they can get this information and what we've got available out to our communities and to people that maybe wouldn't realise it's there. So they're in that scoping stage at the minute to try and work out what works, how can we get people aware of all these various things that are going on, because there's absolutely loads of things that are happening, but you're right, if you don't know, you don't know and you can't attend. So we're hoping to see some output from that work in the next year.
And just clarification on your, what does NLAG and NWAF look like? It's within your pack, but it's known as the ICB target. So there's 2 targets. One's the ICB and one is ULHT.
Okay, thank you very much. That is all the speakers I've got down now, so I've just got a couple of questions myself. My first question is, on page 33, what is the timescale for acquiring a second robot, and have you secured funding for this yet?
So the funding business case is being developed, that's my understanding, and so that is yet to be secured, but the timescale for that is within this, I'm hoping within this year, so by March this year, but it'll have to escalate up through NHS England from a finance perspective. I don't know whether Chiro's got any more on that from a robot.
No, I'm afraid that's the same I have. So not further update.
Okay, thank you very much. And then on page 36, can you expand on what further steps are being taken to stabilise gynaecology? And if these are not successful, what are the options you could be looking at in the long term?
So stabilise from a workforce perspective, yeah. So there's been a lot of money gone into gynae this year from the East Midlands Cancer Alliance, and that has pulled in nurses, workforce nurses, ACPs I think they're called, to ensure that the nurses, they're taking on those consultant roles to support, or support the consultant roles, but in an extended role. And that's then managing the areas around that postmenopausal bleed pathway. Katie, can I just pull you in there from a gynae perspective, just around the detail of how we're supporting that workforce? Can you add any more?
Other than to say we're looking very carefully at the postmenopausal bleeding pathway, so we maximise the resources we get and also ensure that we're adhering to the guidelines and making sure that the patient flow goes in the right direction. So therefore, maximising the investigation and capacity that we have within the system, but not over-investigating women who may not be needing onward referral and therefore can be more appropriately managed by the GP. So it's using the capacity we've got, whilst additional capacity in terms of menopause nurses is coming in and the plan for the future.
Okay, thank you. On page 38, when do you expect the outcome of the workforce review and what is likely to be attributed to workforce consolidation?
So that's the Living with Cancer programme. That's looking at the workforce from a wider perspective of for all roles. That's ongoing at the moment. We've written a strategy this year, and it's now being we're trying to work through those actions to take. But it is an ongoing piece of work around workforce.
Okay, and what about the workforce consolidation element of it? What will that entail?
If we can come back with that, that would be helpful.
Thank you. And my very final question, can you give an approximation of the overall number of patients diagnosed and treated for cancer each year by ULHT, please?
Diagnosed and treated. So, again, can I bring that back?
No problem at all. In which case, I'm going to move to a proposal, thank you, that we thank the presenters for their report and contributions of all the staff to the Cancer and Living with Cancer programmes, and that be recognised, and that efforts to be supported to plug the gaps in recruitment and retention, and a further report to be received in 1 year's time. Do I have a seconder for that? Thank you, Councillor Burke. All those in favour, please show. Thank you. That's supported unanimously, and thank you to our presenters. We'll now move on to agenda item 6, review of urgent treatment centres. This item was circulated as part of the agenda pack on pages 65 to 74. The committee will recall that the Grantham Urgent Treatment Centre was considered in July as it was out of scope of this review. Stamford Mine and Injury Unit was also excluded from this review as stated on page 67 of the report, as it is not designated an urgent treatment centre. I'd like to welcome our presenters in person. Darren Fradley, Chief Integration Officer for Lincolnshire Community Hospitals, and Claire Raybould, Director of System Delivery for NHS Lincolnshire's Integrated Care Board, and Rebecca Nino, Deputy Director for System Delivery, NHS Lincolnshire Integrated Board. And I'll hand over to you for a quick walkthrough and we'll take questions at the end, please. Thank you.
Thank you, Chairman. Yes, so I will take the paper as read, but just walk you through some of it to bring it to life a little bit. You'll recall we mentioned as part of the urgent care update that we bring here annually that we had commissioned a review of urgent treatment centres, basically to ensure that they're adhering to the standards that were updated in October 2023. So there's a refresh of principles and standards, as you can see in the report. And we wanted to ensure that our urgent treatment centres were meeting that need, but also we were aware, and HOSC had previously raised this to us, that we had on occasion had periods where we had to close some of the urgent treatment centres for periods of time, which obviously was unhelpful and not great for our patients. So the report kind of details really the first bit is the background and context of urgent treatment centres. HOSC might remember we had a plethora of different services across the county, and then we did some work and some engagement and dedicated, or designated should I say, some of them as urgent treatment centres. At that time, Stamford was part and is still part of North West Angular Foundation Trust, and they had their own plans for what they were doing with Stamford, working with the GP practice at the time in Stamford, but things have moved on. We've kept that out of scope for this because, as you will be aware, we are going to commence piece of engagement work in Q4 this year around Stamford services as a whole, and felt that needed to be included in that work. So what we've done is we've looked at, you can see on page 66, what you're expected to have in terms of urgent treatment centres and what the minimum expectations is of them. So being open 7 days a week, minimum 12 hours a day, and then you can see all of those standards in there. I won't read them all for you. So our review was against where do we sit in terms of that for all of our UTCs. So the scope involved the 2 co-located UTCs, so one at Lincoln, one at Boston, so they sit in front of our emergency departments at Lincoln and Boston, and then the standalone ones at Gainsborough, Spalding, Louth and Skegness. And as you've mentioned, we kept Grantham and Stamford out of that for reasons we've explained, but also there are some primary care practices that offer urgent treatment. They're not designated urgent care centres because they can't be by definition, but primary care are allowed to offer minor illness and minor injury services, so they're out of scope as well. So the key findings you can see in section 3.1 on page 67, the attendances, and we've looked right back to pre-pandemic because we thought actually looking through the pandemic isn't necessarily helpful. We know we saw a lot less visitors to Lincolnshire during that period, so we've gone back to 2018 and looked at the attendances. And since recovery from the pandemic, you can see that everywhere has kind of increased a bit. Apart from Skegness, that still remains really low. But we also know that we haven't got the visitor numbers in Skegness, perhaps post-pandemic, that we had before. There is some seasonal variation that is particularly notable in Skegness and Gainsborough, but it often gets offset by summer's busy for us because we have more visitors, winter's busy for us because by definition people have more urgent need for some conditions in the winter months. The number of out-of-area patients seen at Skegness and Gainsborough are significantly higher than the other Lincolnshire sites, and that's by definition for the visitors we have on the coast, but also Gainsborough. It's the nearest place for patients that are out of county as well. And then you can see on page 66 at the top the numbers of the transient population. You asked us to include that, so where that's our visitors. So you can see there very clearly the numbers at Gainsborough and Skegness that are much higher than the other sites in terms of those visitors. There's huge variation in the attendances at the sites throughout the day, and that's particularly noticeable at Louth and Skegness, which are the 2 standalone ones that are open 24/7. The other 2 are only open 12 hours, and they decrease significantly during the overnight period. So you can see in the report there the numbers that attend Louth and Skegness in the overnight 8 p.m. till 8 a.m, but it's significantly lower when you look at the 10 p.m. to 7 a.m. period. So on average 4 patients at Louth and 5 patients at Skegness, and that doesn't change in the summer either. It's pretty static in the winter to the summer, probably for reasons you'll have more people with presenting problems in the winter, and in the summer visitors. And actually when we looked at it, the visiting population aren't the users of it overnight, it is our resident population, if that makes sense. So when we looked at that, obviously you can see we looked in detail at the overnight period, because that's where we were having the problems, as you'll know from staffing. It becomes quite difficult to staff in the overnight period. You tend to have quite skeleton staffing because of those numbers, as you can see. And then obviously if one of the 2 people phones in sick, it's very difficult to run a safe service, and Darren might want to comment on that a bit later. So we have also put some information about the seasonal variation in overnight attendances, and actually what you can see is the predominant users of overnight is between 1 and 24, which we were quite surprised about. We thought it might be an old population using it at night, but it does tend to be children. So we then looked into, as you can see, what people are using it for. And we also looked at how they're getting there. So most people are going by their own transport, so to get to the sites, as you can see. So when we looked at attendance, reasons and diagnosis, so this is for the top 4 diagnoses for all of our UTCs. It's tonsillitis, upper or lower respiratory tract infections and sprained ankles. And additionally, we looked at the attendances overnight at Louth and Skegness, just because we could see the difference. And you can see it's very similar in terms of what the attendances are. And actually, quite a lot of those could be dealt with, and this includes daytime hours at all sites, if we did push more on our communications about what we used to be called Talk Before You Walk, but it's 111 first. So if you do call 111 first, you can be booked into a timed appointment, whereas if you just turn up, you have to sit and wait. And quite often patients will say to us, and Health Watch have picked this up in reports, that the patients don't understand. If somebody turns up at 7 o'clock at night and a patient walks in at 8 o'clock and is seen straight away, they don't understand, but that patient has a booked appointment. So unless you've got a clinically more urgent need, you wouldn't trump the booked appointments. So booked appointments are always better. But also we can make sure that people are going to the right place. So as you can then see at bottom of page 69, we looked at the X-ray opening hours, which is one of the standards for UTCs, and you can see that for Spalding, Skegness and Gainsborough, that stops at 5 o'clock in the weekdays, and we don't have any access weekends and bank holidays. So if you did attend with a sprained ankle, then you will have to come back anyway for your diagnostic. If you'd called first, and that was obvious from the clinical triage, you may have been booked into a slot then as soon as that opened where the diagnostic is available. And there's some opportunities for us in the future to link to community diagnostic centres as well, as they come online. Whereas at Louth we do have better access to X-ray, as you can see in the pack. The low number of attendees at the, after the 5 o'clock at any of the sites would indicate that it wouldn't be financially viable to recommend extending X-ray opening hours at those sites. And actually, if we can use the 111 first, as I've said, we could probably make sure we're directing people appropriately anyway. And there is evidence now that people are using Waitlist, which is our app, which kind of shows you what's available and how you can get to and the times. So people are able to see within Lincolnshire. That said, it doesn't include sites outside of Lincolnshire at the moment. People can see what those times are. So that might be why people aren't presenting outside of those hours. From a referral source, so urgent treatment centres are open to patients that walk in, but we also offer booked appointments, as I've just mentioned, and that's a real opportunity for us, I think. What we've got at the bottom of page 70 is the table of the percentage of patients that currently talk before you walk versus the ones that come in through our 111 route. So that's just quite interesting to note the differences. We've also included at your request the ambulance conveyances. So these are people that are taken to any of the urgent treatment centres, and you can see that information at the top of page 71. We also had a look at where patients are registered with, because there is a link if you think of the fuller review of primary care. And you can see there in the pack on page 71, the kind of top presenting. It'll always be usually the practices that are closest to it that's quite natural, and that will be sometimes patient choice, or it might be driven by general practice when they exceed their capacity. So that information's in there. You will note there is one that's a Nottinghamshire ICB practice, but obviously it's closest to Gainsborough, so that's why they use it. From a capacity and staffing point of view, they are staffed with highly skilled nursing and support from medics remotely, and that's because obviously they are standalone, these sites, so they need to have highly skilled people available. In the overnight period, we have 2 senior advanced nurse practitioners to maintain safe staffing levels, and due to the limited numbers of patients on those sites, I do think that's something we need to look at in terms of, are we making the best use of those skills? What else could we be using them for as well? Demand has been steadily growing since the pandemic, as you can see that, except for Skegness, and we have increased staffing in line with that in our urgent treatment centres, and that's partly why we're not having so many issues this year as we were last year, because we have increased the staffing, and that has led to us not having any closures. In fact, I don't think we've had any in the last 12 months, which is really good. So in terms of the key findings, I think the review and what patients tell us is urgent treatment centres in a county like Lincolnshire that's really rural are a really important part of our architecture, and we absolutely need them. Patient experience says they're really valued services, and you can see that in the attendance figures that are all increasing apart from Skegness that we've already talked about. It is clear that overnight usage of Louth and Skegness is low, and there's an opportunity for us to engage with that population on the benefits of talk before you walk at all times, and I think actually across the whole county, to be fair, but also in the overnight period, and that could lead to better patient experience and better use of our skills, but that's just something we need to explore. Staffing levels and demand may not always be appropriate, and we can see that, and there's something about workforce retention and staff feeling comfortable as well. And our X-ray provision is not consistent, as you can see. I think there's an opportunity for us as the community diagnostic centres come online, particularly at Skegness, to think more about how we could book patients in for their diagnostic there instead of in the overnight periods when it's not available. Currently they would go to Boston or Lincoln, which is too far. So some opportunities for us to look at. So in terms of our next steps, you know, as an ICB, we're continuing to deliver the ambitions of the Urgent Emergency Care Recovery Plan that we've talked about to you before. And I know Sarah Jane's been and talked about the fuller review and primary care as well. We do need to do more around a single integrated urgent care pathway. I think we've had, and we've said this when we've been before, quite a lot of single services not very well integrated, and I think there is an opportunity for us in Lincolnshire, and that including all wider parts of the pathway, so our 111 service, our clinical assessment service. We tried acute respiratory hubs last year. They didn't work particularly well in Lincolnshire, but when you look at actually the top presenting conditions are respiratory, actually we should be doing that through our urgent treatment centres because people know them, they know they're there. That would be the most obvious place for those pathways. So there's some work for us to do there, and I think there is a big piece of work for us to do on communication with the public on how to access these services to get the best patient experience and outcome when you do attend and be directed to the right place. So hopefully that's a smart enough summary for you, and happy to take any questions.
Thank you very much for that. I've got Councillor Cleaver first, please.
Thank you, Mr. Chairman, and thank you for the report. Thank you for your introduction and your comments on Stamford particularly. They are welcomed. I think I heard you say that the integrated strategic review of Stamford is to start before the end of this year, if I heard correctly.
Yes, yeah. So
okay,
currently we're working on an assumption that will start in Q4, so that's the last 3 months of our financial year, so January, February, March.
Thank you, that's good to hear that. You also mentioned the app. I've mentioned the app before. Do you have a date by which it will integrate with the adjoining ICBs?
We don't at the moment, and I know you've asked before, and I apologise. So obviously we can control it with our providers. We have discussed this with other areas, whether they're looking to use it or not, but we've not been able to move that on at this stage. So, we will keep trying that. We do recognise it doesn't include where you're on the border. You can't see where somewhere might be nearer.
It is actually very interesting to see. I'm looking at it now. Where the queues are, literally. I mean, it's saying that if I live in Stamford at the moment, it's saying go to Boston, 2 hours, 30 minutes, 14 patients waiting, and the longest current wait is 1 hour and 36 minutes. So it is actually, it's full of rich information, but it doesn't obviously tell me to go to Peterborough. A couple of things that I pick up from the report. Obviously, it's a piece in the jigsaw of a large piece of work about urgent care, and I accept that. Notwithstanding that, one of the things that I think is important still to emphasise is the overlap with the out-of-hours GP service, which is important to many people, and there's little reference in the report to that. One of the other things I noticed looking at the NHS England's website, where it describes UTCs, is that one of the prerequisites is that they must have access to patient records. And I wonder if in Lincolnshire particularly we have an issue with that at our UTCs, given some of the issues that we've currently heard about electronic records at the hospital trust within the county. Are we confident that when patients do present, that their records can be brought up electronically as necessary and quickly? And I think that's what's on my list. Thank you very much. Cheers.
Thank you. I'll make a start, and Darren, you might want to come in. So in terms of the out-of-hours GP, so you're right, it's not explicit within this, but what the community trusts do, who run our out-of-hours services, they do, if you need a booked appointment, it would be an urgent treatment centre that you go to, apart from in Stamford, where obviously it is a separate out-of-hours service. So yes, it's not explicit in here because it's part of our primary care offer, but absolutely we do recognise that, and we are able to to understand how many of our presentations are out of hours, typical out of hours presentations. In terms of the records, so we have a shared care record in Lincolnshire which can be accessed by clinicians anywhere, and the service for the treatment centres runs off a service called System 1, which also integrates with our primary care practices, which the majority are on System 1, but some are on EMIS, so they do share those records. In terms of patients outside of the county that visit, I'll ask Darren whether he knows what access we have, but I suspect it'll be the spine records which we can access.
Yeah, sure. So absolutely. So it's what we call the summary care record. So it's a spine record. So you can get that for any patient in any setting anywhere in the country. It's not as detailed though as the shared care record. So it's just recent attendances, high-level past medical history and medication. So there's definitely some work to do there. In reference to some of the challenges we see in other parts of the system, obviously that's part of the electronic patient record programme, specifically the hospital, but the shared care record is a single version of the truth.
Thank you. I've got Councillor Morgan next, please.
Thank you. Do we have, so I have gone through and I couldn't find it, what the actual waiting times are, and any targets that we might have around that, and if we're achieving those. And do we keep a record where patients come to the UTC but actually their conditions are such that they need to go elsewhere? So we have an understanding of what percentage of the patients are actually being properly dealt with first time that they walk in.
Yes, so there are targets for urgent treatment centres in terms of time, so absolutely we can get you that information. At the moment, our average is about 93% of our patients are seen and treated within the 4-hour target, so it's really very strong for Lincolnshire UTCs. I think the national average is about 90 or below that actually, and there are times when ours is at 98%, so we benchmark really, really well, and it's one of the really positive things that people come and look at in Lincolnshire. How have you managed to do that? And I think it is because we've got such good services around the county. So in terms of numbers that come in and walk away, I'd have to check how that's recorded and how we pull it, but it tends to be if somebody actually gets there and they've been assessed and they are of an nature that needs to be sent somewhere else. So we do sometimes have patients where actually they probably need an emergency department, but they've presented at an urgent treatment centre and then they have to be taken. And that's why the calling 111 first is really important and for the public, because actually if you do get there and then you have to wait, you're then going to have to wait for an ambulance to take you. If you can't get to the, particularly if you've got a presenting condition. So, whereas if you'd called first, we're able to clinically assess and work out where you could go. But yeah, we do monitor that information. But I don't know, Darren, whether we record where they go to afterwards.
Yeah, so that's definitely a gap for us at the minute, is the outcome. And Claire referenced a couple of minutes ago about how do we join up all of the services, particularly the ones that are in this kind of urgent care space. So we know we've got urgent community response teams, the clinical advice service, which is linked to 111, and a variety of other teams that work with both the community trust and GPs. What we're not monitoring at the minute is where the patient goes next, or whether their disposition is resolved, and therefore spotting the duplication or not, or actually the poor experience in the system. So it's one of the pieces of work that we're looking at, particularly for winter and then next year, is how do we connect all the teams together so that they can work in unison, but more importantly, spotting both the patient and the citizen's journey through the system.
Thank you. I've got Councillor Burke next, please.
Thanks very much, Chair. Going to page 70, and you've already talked about the massive disparity between people who just rock up and people who use 111. So, and also I referenced the app that Richard just mentioned as well as, I guess, another access to services. I mean, we often struggle, don't we, as organisations and about modernity, about people who can't access the internet, can't access stuff. So 111, that's great, it's a telephone. But I want to think about both because, and it's interesting that Lincoln's got 25%, so that the highest percent of people who've actually booked on 111. And I wonder if that's about young people, I wonder if that's about university students and more towards modernity. And so there's a missing column, first of all, how many people turn up because they've used the app? Or are they included in the 111 telephone figures? It'd be useful to see that separated. And then there's a very obvious point, which I think is a responsibility of all of us and all organisations. How well can we publicise 111? Because clearly it's not, I mean, it's on my kitchen board, 111, to remind me that that's an easily available service if anybody needs it. But, you know, in you know, city council receptions, in, you know, the whole range of other areas, is 111 uppermost in people's mind when we give advice. You know, should there be a massive, well, there are campaigns, aren't there? We do see television campaigns about 111, but the disparity is massive, isn't it? It makes us think, what else can we do? But could we see that other column? It may not be recorded. So, I mean, I might be asking for something that's not available, but I'd love to see the app thing as well, and that promoted, because there are a lot of people now using apps. Thank you.
Yeah, thank you. So, great question. In terms of the Waitlist app, we can't do that at the moment because it's an information app. It doesn't track what you then did afterwards. It would only, when you get to your destination, they do often ask why, you know, how you found us kind of thing. But so let's think about that one, because we certainly can't track it through the Waitlist app, but whether we can do it differently. I think with Lincoln, some of that actually, where you see the high numbers, some of it is demographic, but some of it is patients that go into the ED and actually they don't need the emergency department, so they're streamed into the urgent treatment centre because it's most appropriate. So that's why you will see sort of slightly higher numbers at Lincoln, I think. And that's replicated at Boston as well, but I think there also is a younger population at Lincoln, so you're quite right. But absolutely, in terms of 111 patients, I'll check whether we can break down whether any of those are online or telephone 111. I'll see whether we can get that or not.
Councillor Geeney.
Thank you, Chair. This is a bit of sort of personal thing. I had a suspected damage to my foot or something, and I did actually speak to the surgery, but they said go to the urgent care centre at Spalding. Whether I made a mistake in saying, you know, I'd spoken to the GP or spoken to the surgery, and they'd advised me to go there, but after I'd had the x-rays, they said, we'll send them back to your GP, and they did get them back to my GP 5 weeks later, after me having rung up about 3 times every week. Was I just unlucky? Did I do something wrong? Or is this something that shouldn't happen? Thank you.
Yeah, firstly, sorry to hear about that experience. We probably have to look into it to see what happened, because there is a GP referral for x-ray. So what I'm unclear is whether they said, go and have an x-ray and sent you with a form to go and have an x-ray, and then the result would go back to the GP. If they'd referred you specifically to the urgent care centre, they should have completed your treatment there. So we'd happily look into that offline. I don't know, Darren, if you want to add anything.
If I can just say, I was just told, go. They said there isn't a referral or anything, you just turn up.
Yeah, that's definitely something we'd want to follow up. Specifically, if you're required to have an X-ray when you attend a centre, we'd usually kind of give you the results and take the relevant action as well. So I think we need to take that one offline and definitely have a look at that for you.
Thank you.
Thank you, Councillor Martin.
Thank you, Chairman. Yeah, I'm just surprised the lack of like a full customer journey tracking with all this. So you can't actually give us full statistics of, you know, where the patient started into UTC, where they've gone to after that. We actually had a similar thing with Grantham UTC, which we looked at a couple of months ago, where when asked, the patients in the UTC, do we ask them how they got there, have they tried the GP, what routes have they tried? The answer basically was incredibly weak. We don't do it. And obviously, from this viewpoint, it's all very well saying UTCs have got these numbers of people coming in, but if half of them have given up with the GP, they've tried phoning, they've tried this, they've tried that, and they've been forced into this, you need to know. So I would strongly suggest you get a proper customer tracking facility in and a full understanding of where people are coming from and obviously where they're going, because otherwise these numbers are all well and good, but they're kind of not showing us the meaning of why they're there. Thank you.
Yeah, I think it's a fair challenge, and I've done a number of these things over the years where we've tried to look at that, and then we've triangulated back, and actually there's no evidence that a patient's contacted the GP practice at all, but when they've presented, they've said, I couldn't get in with my GP. So sometimes you can get a false assurance when you look at it, but we don't routinely track it, probably for those reasons. But in terms of the onward journey, I think that's a fair point. We absolutely could put that in here. We could tell you how many people are seen it. And the majority of patients will be seen and treated within the UTC and not have to go to an onward travel. But some of the periphery sites where if you've attended with something that perhaps then you might need to go to an ED for, but that would be okay, because that means you've presented with something that can't be dealt with there. But again, that probably highlights back to the comms. So I think it's a fair challenge. I think it's just how you do that, because you get a lot of anecdote at frontline services that people will say, I've tried this, I've tried that, so then I've come in. And equally, the entry points are multiple, aren't they? They can walk in, they could call 111, they could go online. And if somebody puts something online, it's whatever they've put. And we've listened back to calls in the past where we've had patient complaints, and actually when you listen to the call, there's certain triggers that are said that might send them in a certain direction. It's not that anybody's doing anything wrong. So it's just quite difficult to look at that data and do a really good analysis of what that tells you. But I hear what you're saying about the tracking the ones that we do see and what the endpoint is. Absolutely could pick that up.
Yeah, thank you for that. It's just really that obviously a lot of patients have a lot of time sitting waiting, and to ask them questions or even hand them a card or stick a sign on the wall saying, please just fill this in whilst you're waiting, be very easy to do, very inexpensive, and you might get some really useful data.
Yeah, no, great suggestion. So thank you. Yeah, we will.
Thank you, Dean.
Thank you, and thank you, Claire, for the presentation. And as a Health Watch, I think we agree with the patient experience in terms of how much they value the UTCs. I guess my question was in relation to sort of more NHS 111 and a continued sort of reliance on patients and the public kind of using this service. We have, as Health Watch, sort of had patient experiences where they have been given sort of incorrect information, or they've gone to a UTC and found that it's been closed. And so I suppose it's just reassurance really that that NHS 111 are given sort of correct local information, that they are then sort of forwarding that onto patients. So because we are also finding that once someone has one bad experience with NHS 111, that they then continue not to use it. And I think if we are going to continue that reliance on 111, that they need to be reassured that that service is going to work and provide them with that sort of correct information.
Yeah, no, you're absolutely right. And so we do monitor what happens with 111, and that's why I just referenced that we listen to some calls. Sometimes it's where we do get patient feedback about what's happening, and sometimes it is wrong. And I think what can happen is perhaps sometimes people use their memory rather than actually look on the system. But we hold what's called a directory of services in Lincolnshire that we manage in Lincolnshire ICB. So it includes all of our services. So if, for example, when we did have the situations where one of ours was closed, then we would change that on the directory of service, and 111 see that immediately, so they would know that it's closed and they should be able to give that information. I think when we have looked at the odd one where that's not been the case, it has been, I think, evidence where we've probably not used the directory of service. The new we've got a new contract with 111 that started in July. And we have had some teething issues, I would say, with that contract going live because they're across a bigger footprint, and they've obviously had to get used to a different level of volume. But we are seeing sometimes where we are getting anecdote of patients not appearing in the right places as a result of calling. So we're monitoring that really closely at the moment. But what we are seeing is much better performance from answering calls. And so when you do get through, generally speaking, the advice has been better, but we are continuing to monitor that quite closely.
Okay, no one else has indicated at the moment, so I'll bring you in after I ask my questions now, Councillor Mackinson-Saunders and Councillor Wesley. Reading through the paper, it seems to me very clear that the ICB is considering closing both Louth and Skegness UTC for walk-ins overnight between the hours of 10 p.m. and 7 a.m. So can you please advise what your next steps are? Will you be consulting on any changes? And how soon are we likely to see changes at either of those two sites?
Okay, so I mean, at the moment, we have no plan to close either of them overnight. What I do think we need to be honest about is the data's telling us that we've got highly skilled, valuable resource there overnight. We're not making best use of it. And at the end of the day, it's public money. We're servants of public money as well. So I do think we need to look at what the opportunities are, but we need to do that in engaging with the public. We need to go out and talk to the patients in Louth and Skegness about their experiences. So the very small number that do come overnight, how could they be best served? Or actually, is that the only option that we've got, is to retain those services overnight? There are places close to us on the border. So Newark, for example, moved to, I don't know what their times are, but they closed theirs overnight. They had similar numbers attend, and they moved to a home visiting model. So the teams that are currently working overnight moved into the home visiting teams. So if somebody really did need to be seen, they would go out and see them. So they weren't not seen, or they were directed to an appropriate service. But that's way down the line. At this stage, what we're saying is this is what we've found. We can't ignore what we've found because it's really not the best use of that skill set at the moment to just ignore it. But actually, could we do something different if we engage with the population about how we use our 111 services? We do the integration that Darren's talked about with his services. What would that mean? Better use of the app? Actually, would that change to say we have more or less people go overnight? Or actually, could we look after those patients in a different way and their experience be better? So our ICB medical director couldn't be here today, but if he was, he listened to a patient recently who needed to attend in the early hours of the morning and got 3 children. Actually, we could have booked them into an appointment with what they were presenting with, but actually now currently they would just go and present and wait overnight. So I don't think we've made any decision. We're just saying we absolutely need to look at it. We're being transparent. This is what we've found. So the next steps really, I think, are for us to do a bit of engagement. We need to work with Darren and his teams out in there. We need to talk to the staff as well. So there's no timeline for this. There's no, we're not rushing to do anything really quickly. I think actually our first step should be, let's really push the communication around using 111 First across the whole county, and let's see what that does in terms of the access at all of our sites. And we might then come back and have a very different picture, might we? So I think we need to do that work first before we make any quick decisions. But Darren, I don't know whether there's anything you want to add to that.
No, I think you've covered it. Thanks.
Okay, thank you. I've just got 2 more questions. First one is, the report refers on page 72 to security issues at Louth and Skegness UTCs. Are you able to elaborate on the type of incidents that have led to need security?
Yeah, so when we look at them, particularly the population demographic in Skegness, we see that we've got quite a lot of people access the services that have got dependency issues on drug and alcohol. Often with those, not always, but often with those, we see escalations of threats to staff and unfortunately acts of violence as well. And particularly in Skegness, we've had to put what you would typically find as that glass screen
similar to what you'd find in post offices, banks, etc., because of that sort of violence. So we can't leave clinicians in those environments without security. I haven't got any specific references to the other site, but if committee want them, I'm quite happy to find them for you.
Thank you. And my final one is, how easy is it to pre-book an appointment at a UTC using NHS 111? And does NHS 111 initially offer alternatives to attending a UTC in person?
Thank you. I can actually give you a live example of that, actually. So not only do I do my job here in Lincolnshire, I'm the Lincolnshire resident right in the south of the county. And I'm a mother as well to an 11-year-old who Saturday afternoon developed quite a severe earache, which I wasn't too concerned about because we'd come back from the holiday. I decided to get it checked out. So I called 111. My call was answered actually instantly. It was 5 to 5. And I thought, this isn't going to be good, is it, on a Saturday night, as we're all probably thinking. The call was answered instantly, and I was triaged through into requiring a 2-hour response and a further assessment, which went through into our Lincolnshire clinical assessment unit, run by Darren's staff. They originally called me back within about 40 minutes by a nurse practitioner who said, this probably does need to be looked at, but we have a GP available. So you've got two choices. You can either book into my local urgent treatment centre, which by this time was 6:30, it closes at 8, but they had got capacity to book an appointment for me. Or I could have a telephone triage with a GP over the phone. So I opted actually for the latter. So Saturday just gone, I had excellent service. I had a GP assessment. He called back after about an hour, and she was prescribed some antibiotics I was able to collect from the pharmacy. So very recent example of how I had choice through the urgent care pathway. Now, I also, prior to making the decision to phone 111, I looked at the waitlist app, because obviously I do know, and there was quite a number of people waiting within Spalding Urgent Treatment Centre, which is why I decided to call in the first place. So hopefully that gives you a live example.
Perfect. Thank you very much for that. Okay, I've now got Councillor Mackinson-Saunders.
Thank you very much. Well, I can tell you there are 26,000 extremely grateful patients in Louth, and we could not, and I think that illustrates the paucity of other services. I won't say any more because I'll be struck off a list, won't I? But basically, we can't do without it, and thank you so much for the service that you do offer. My family, all my family have been through there. We've had really good treatments, such nice staff. I couldn't praise them more highly. I wouldn't close it at 8 anyway, I'd close it at 10 because there's still quite a lot of people going in at 8 o'clock at night. But it really is a much needed service for us. We can't do without it in Louth. And I did have to laugh where on page 69 it says, at Louth, overnight attendances by public transport are extremely low, because you do damn well to find a bus anywhere in where we live, let alone anything else. So, you know, we do have to be realistic about these things. But I know my daughter-in-law has used that service in the middle of the night when she had an allergy and her throat closed up. If she'd had to go to Grimsby, she'd probably have died, actually. So, you know, there are people who do need these services. And I think I don't know how you're going to go out and ask the community, because we were just discussing that earlier. We need to get people who will shout and say, you need to keep that going, please. And I have had a wonderful experience with 111. And then I went to my GP after what they had told me exactly what to do. And they laughed at it and said, oh, that's what rubbish. I'd had a pain specialist nurse phone me back, and the nurse at my GP's told me what she'd told me. Oh, no. And gave me 100 paracetamols. I rest my case. Rubbish. Thank you very much for your service.
No, thank you, and I'm sure Darren will take that back to his team, so thank you.
Thank you. I've got Councillor Wesley.
Thank you. What I'd just like to say is I think that, you know, the report is really good, but what it doesn't really illustrate is the growing issues and problems that are being faced in the rural parts of the county. So my ward, Market Rasen, represents quite a large percentage of the rural population. It's an area with a growing population and, more worryingly, an increasingly ageing population. We have a GP surgery where the remaining partners are retiring and struggling to attract anyone to take it over. So we're being serviced by locum GPs who only work part-time, so services are extremely stretched. With a lack of public transport available to either Louth or Gainsborough and a very sparse service to Lincoln, residents in the area without vehicles are unable to access any of the UTCs in the area. With that ageing population, I would suspect that what is happening is that this will be resulting in increasing admissions to hospital for conditions that could have been treated at an earlier stage, or even illnesses going undiagnosed and untreated. The models that you're using work well in an urban conurbation but fail to tell the full story for a rural population. What myself and fellow district councillors would welcome is further investigation into the possibility of a UTC within a more rural area, which will provide an accessible service to villages via the Call Connect service and alleviate the pressures that are on local GP practices. And just secondly, I'd like to say, do you think that the overall demand increase in UTCs across the county post-COVID is due simply to the lack of access to GP services?
Yes.
Yeah, so thanks very much for your question. You're absolutely right. On the in kind of the rural areas that you mention, it's incredibly difficult to get the coverage, and then even when you put that coverage in, you can't always meet the needs of everybody as well. So what the work that we referred to, which is outside of this report, about looking at how do our community services work, and also how do they work with primary care, is intent on directly addressing that. So how do we get integrated neighbourhood teams that can cover bigger parts of the population that are more accessible, and I'll work with the GPs. That's the first point. The second point is you'll see that community services and acute services have come together into the group. We're now starting to have conversations with GPs and primary care about how do we make the services a universal offer so we can link everything together. And specifically for the practice, and I'm not sure which practice you're talking about, but the practice where you've got locum cover and retiring partners is exactly one of the areas that we're starting to focus on to make sure that we've got sustainable primary care and services as close to home as possible. And I know there are challenges at the minute. That's not unique to Lincolnshire, but they're definitely challenges. So sometimes delivery of a functional building or delivery of a functional site isn't the answer. Sometimes about having that multidisciplinary team assessment and then making sure that the local residents know how to access it. And when you can connect those two bits together, home is often the best place for us to look after you. So we'll come to you rather than you coming to us. But there's a lot of steps on that journey, and that's what we're working through at the minute.
Okay, thank you. I've got two more speakers and I'm closing down the debate. So I've got Councillor Matthews on Teams first, please.
Thank you, Chair. Sorry, just fumbling with my mic. I'm bothered by the reportage about, if you like, the threat of closing Louth UTC and Skegness UTC, and I really would like to see the hard data. I mean, are these doctors sitting there doing nothing from 8 o'clock in the evening until 9 o'clock in the morning, or is it the occasional night? And I want to put forward that conjecture that a lot of us in this community have lost confidence in the UTCs, and where we might have thought, oh, well, I'll just pop down there because I really don't feel very well. We've been anxious because they've been closing of their own volition anyway. So I think that needs exploring a little bit more, that it's they've got understandably there's value sitting there, but there's got to be a better way to promote the
usage and engagement with the UTCs, because it has fallen off because of a lack of confidence in their availability. Thank you.
Yeah, if I take the first point, I understand if there's a lack of public confidence in availability. I mean, we haven't closed any for over a year now, so it's disappointing if that's what people think. But certainly we could do some work on that from a comms point of view. So there is more data that sits behind this. As we've said in the pack, it is in there. It's an average of 4 patients at Louth and 5 at Skegness overnight. There's no GPs. GPs don't work in urgent treatment centres, so they're staffed by senior advanced nurse practitioners, which is also I referenced earlier and is in the pack. They do have access to medical support if they need it, but actually that's the right skill set for these services. And as evidenced in the Health Watch reports and our own engagement events that we do, or listening events talking to the public, they're really well valued. So obviously if you've got additional information you want to share with us to the contrary, very happy for you to do that, and we'll take that on board.
Okay, thank you very much. I've got Councillor Smith next, please.
Thank you, Chairman, and I thank you for your indulgence. It is a very brief point, and it focuses on what Councillor Wesley was already mentioning. My Warden division is even more rural and even more sparse in population and actually in age. I'm just looking at the software we have at County Council for age brackets in terms of population, and the highest number in terms of populace, in terms of age, is 56 to 60-year-olds. In terms of females, and in terms of males, it is 61 to 65 years old. So quite simply, if they are not able to drive, Chairman, in vast parts of my Warden division, a UTC is simply not an option. So I welcome the points that Darren's made, and I'd very much like to offline, as it were, have a more detailed conversation about how that actually works, because actually in rural Lincolnshire, that's what's needed. It's not a building actually in a rural conurbation. In an ideal world, yes, we'd all have a building, we'd all be able to go to it, we'd all be able to access it. In reality, that doesn't work. So it's how that multidisciplinary team will actually work. And it's also getting the public confidence to use a service like that, because you'll have a lot of people who are of an age, and I'm granted I'm not quite there yet, Chairman, but when people say to me, care in the community, the conurbation that used to have was that means it was done on the cheap. I know that isn't the case now, but it's getting rid of that stigma of it's done on the cheap, and it's giving them the confidence to use such a service. So I very much welcome a conversation offline and how that's going to work in practicality, because a building, certainly for my residents, simply isn't an option. And some of them actually, Chairman, will go to Grimsby anyway, because my residents sit right on the border, and some will actually go to Scunthorpe because they're right on the border. And we both know, Chairman, from other roles we've had, the difficulty that ensues should they actually need a hospital admission and then getting back home. But no, thank you for your indulgence, Chairman.
Thank you. Okay, in which case I'm going to move to a proposal that the contributors be thanked for presenting the item information on the review of urgent treatment centres, that the positive contribution of all the urgent treatment centres in Lincolnshire to the emergency and urgent care system, including overnight services in Louth and Skegness Urgent Treatment Centre, be recorded, and that a further report be requested when more details are available, removing any duplication and inefficiencies as stated in the next step section of the report. Do I have a seconder? Thank you, Councillor Wootton. All those in favour, please show. Thank you. That's supported unanimously. Thank you. Once again, thank you very much. We'll now move on to agenda item 8, non-emergency patient transport. This item was circulated as part of the agenda pack and can be found on pages 75 to 84 and covers the service commissioned by the Integrated Care Board from the East Midlands Ambulance Service for patient transport in accordance with the nationally set guidance. As much as we like to explore other transport issues today, I suggest we cannot stray too far from the content of this report, which is focused on what is in effect a statutory service. I'd like to welcome our presenters online. Joy Weldon, Head of Non-Emergency Patient Transport for the East Midlands Ambulance Service, and Tim Fowler, Assistant Director of Contracting and Performance for NHS Lincolnshire Integrated Care Board. I'll hand over to you, and if you can just have a run through the paper for 5-10 minutes, as I'll take it as read. Thank you.
Thank you, Chair. Joy will present the report to you this afternoon, and then more than happy to take questions. So, Joy, can I hand over to you to kind of take us through the report?
Yeah, you can. Good afternoon, everybody. So at our last report, it was in January 24. So we've been undertaking a number of actions that we'd like to share with you. So we've now concluded our mobilisation phase of the service, and since January have now been in our transformation phase, which is including the full development and activation of the local incentive scheme, and we've continued then to develop the service with the key objectives, working alongside Tim and his team at the ICB. So we were asked previously to present some information around patient feedback, which is a key element within the local incentive scheme. And without going into and reading all the detail on there, what we do have is the usual routes for patients to provide feedback. So PALS, for example, our patient and liaison service. But we've also been undertaking a year 2 plan, which includes then some more direct ways of gaining information from our patients and also healthcare providers. So although the numbers are quite low in terms of the actual patients that we do convey, as you can see there, that we have had some really positive responses from those surveys, which have indicated satisfaction within the service, but it's also given an opportunity through narrative to be able to understand some of the further areas that we need to look at to make improvements. So in general, there's a lot to be proud of, in particular from our frontline resources and our teams, and the word compassion is used quite a number of times in that narrative, which is really important for our patients and experiences. We've had some challenges in terms of our call centre, in terms of patients having to wait longer than they would have liked on the telephones, which is something that we are currently working on to improve, and also healthcare professionals have raised the same areas. We've also had feedback in terms of where we need to improve, and the key themes for that is timeliness. And so what we're doing for that is, in line with the plan, is ensuring that we're looking at themes, trends, and undertaking any actions that we can to make those improvements. The Friends and Family Test as well is also providing that same level of feedback. It's consistent, and so it enables us to be able to undertake specific actions to make those improvements. Some of those improvements, which will then include and link in with our service delivery principles. So I'd like to just talk through some of those key actions which are also monitored within our improvement plans internally. So we've undertaken a rota review as part of the transition, and so from the 2nd of September we have an additional number of locations where we have resources based. So in rural areas we have Mablethorpe, Stamford, Holbeach, which is really important locations. They were where we have high levels of activity, but also patients where we have delays in attendance, and so that will help make those improvements there. We've also had additional resources now, and they operate 24/7 that are based at a number of acutes. So at Lincoln County, Boston Pilgrim, in Grimsby, and the next location that will go online will be at Peterborough, and so that will help then support improvements within our discharge principles, so that we can start to make improvements there. We've also got a number of actions that work with stakeholders, our hospital teams, particularly regarding discharges. However, although the service delivery principle is quite low in that area, we are undertaking over 90% of those discharges within 7 hours, and so 7 hours is an extreme. It isn't the norm, and that's normally due to a reprioritisation. So we have 63% of our discharges that are booked on the day, and usually within a few hours' notice, and so that provides sometimes a challenge there in terms of being able to meet the 4-hour target as often as we'd anticipated. But we are working very closely with all our acute settings to be able to make those improvements where we need to. Following on from that, we've also made some really positive changes within our renal dialysis patients as well. So there's been massive changes and improvements there. And I do believe Tim actually went to the departments this morning, so it's not just ourselves that undertake engagement, it's also the ICB continue to do that, so that we're all aligned in terms of patient experience and what it is that we need to be doing for next steps and future development. We've Appendix C was also a request from the committee at last meeting, and so in there you will be able to see the activity volumes, and we'll see that there's been a month-on-month increase in activity, and that continues to remain a challenge. However, we are still seeing these improvements and positive feedback from patients. I don't know, Tim, if there's anything else that you want to add to that.
Thank you, Joy. I think I would just underline the way that we try and manage this contract is different to the previous contract. We are working with EMAS really closely and getting into this kind of continuous improvement type scenario. So it's very much about, is there an issue? Do we know what the issue is? How are we going to improve it? And then build on that improvement. I do recognise that there are 3 of the service delivery principles that need work. We've been talking to EMAS about that, and I hope Joy has given some confidence that we are planning around that and working towards improving that through the change in bases. Now, with the best will in the world, changing a base does not happen overnight, so that's been on the cards for a while, but that's linked again to the rota change. So I think generally it's a positive story. There are still peaks and troughs in performance and peaks and troughs in experience. Interesting discussion at the renal unit this morning, and we're meeting with EMAS on Friday, and we'll talk about some of the feedback we had there. But this is about continuous improvement, and I think generally there is a positive story to tell from the advent of the service in July 23, and I really hope we can continue to work in partnership, not only with EMAS but within the wider providers in the system to build on the improvement we've had so far.
Okay, thank you. Questions? Yeah, Councillor Cleaver.
Thank you, Mr. Chairman. I note that your operation of service delivery principles in Appendix B relates to internal targets and internal principles. So I'd be interested to know the distinction between what are your contractual obligations with the ICB and who actually signs off whether your internal targets and principles are actually appropriate, given that they are not contractual. And then digging into the detail, I have to say, and I know it's referred to in the report, but the idea that someone is kept, that only so few people are kept waiting for less than an hour when they're being discharged to die at home is shocking and very unfortunate. And I wonder what measures you can take to actually make sure that that is improved very rapidly. Thank you.
Joy,
Yes,
if I take, sorry, Joy, if I take the first one, do you want to take the second?
Yep, sure.
Okay. So I think the committee will be aware that when we started to look at renewing the previous patient transport contract, we wanted to move away from having really hard target KPIs within the contract. Because if we have hard target KPIs, we need to look at the variation above what the hard target is. So, for example, if there's a target that says 90% of patients need to be collected within 1 hour, you could get a number of patients who are collected in 1 hour and 5 minutes, or 1 hour and 10 minutes, or 1 hour and 15 minutes, and they might feel that that's appropriate. They might feel that that is something that, if they've had good service, if they've had courteous service, if they've been communicated with well, that's okay, even though there's a principle or a target that says they should be collected within an hour. So we wanted to move away from that kind of hard target type approach and move much more to a holistic approach into the contract. In answer to the specific question, what are the contractual targets? We don't really have contractual targets in terms of key performance indicators, and I'll come on to the principles that are in the contract. What we've got is something called a local incentive scheme, and that's meant to incentivise EMAS to identify issues and to get into this continuous improvement type approach. And there are 3 that are in the contract. One is that we want EMAS to deliver really high levels of patient satisfaction and healthcare practitioner satisfaction. And we've had a discussion through the presentation in the report about that. There's a second one, which is zero tolerance on something we call unmitigated rebeds. So where a patient has been due for discharge because the patient transport has not been provided at an appropriate time, we've had to rebed that patient. Sometimes with rebeds, it's not EMAS's fault. It could be an issue that's arisen in the hospital. So that's why we have a distinction there about unmitigated rebeds. And then the third one is around social value. So how does the contract work in terms of promoting local workforce? How does it work in promoting kind of green agenda, etc., etc.? All of that is measured. It's reported on by EMAS. We take a very strong view of that within the ICB, and that will be part of the discussion we have with EMAS this coming Friday. But we wanted to move away from the hard targets and into the kind of more holistic approach, where we know that we've got, or we should know that we've got good patient satisfaction, we've got good healthcare practitioner satisfaction. So concentrating on the things that are important rather than concentrating on the things that are less important. The service delivery principles are akin to the old KPIs. They are there to provide insight rather than to be contractual targets. This is a new approach. We're getting quite a lot of national interest in it, and EMAS are helping us with that national interest. And certainly NHS England think this is quite a good way to go. We have a long-term partnership with EMAS. This contract was originally set for 9 years. 9 months are basically a 10-year contract. And we're really clear that this continuing improvement approach lends itself to that long-term contract being in place. I hope that answers the kind of first part of the question. Joy, can I ask you to respond to the second part, which is about fast track?
Yes, that's no problem at all. So through the rota changes, what we've been able to do is dedicate resource for patients who are being discharged, which gives us an increased opportunity then to be able to respond quickly when we have a request for a patient for a rapid discharge. They often come at very short notice because of the nature of the patient's condition, but also that they can, you know, make that decision at very short notice. And so having those resources dedicated within key areas of the acute settings in particular, it gives us a quicker access to resource that we can make some amendments to and prioritise those journeys. So from last month, there were 8 journeys in total. They aren't high in volume, and 4 that we did achieve less than the hour, and then there was 4 that was achieved within 3. So these resource movements should give us that greater opportunity to be able to respond to those patients.
Okay, I'm going to, if I might come in, just building on where Councillor Cleaver sort of built from, but I've got to say the results of the service delivery principles are really disappointing to see. You've got 1 of 8 exceeding its target, 2 have achieved the target once, and 5 have never achieved the target at all. Principles 2.3, 3.1 and 4.1 are truly atrocious. Do you actually think this is a good enough service for the patients that are using it? What is being done to actually improve this? And can you share any improvement plan with the committee? Because it just seems like a repeat of Tassel.
Do you want me to take that, or do you want to take that, Joy?
You could start. I can provide some parameters if needed.
So I think if I take the last point first, I think we've got some mixed messages coming through from the data that we're recording against the feedback we're getting from patients. So the feedback from patients says that they are generally satisfied with the service, albeit that that's a small sample size. We are not getting hospitals and healthcare practitioners and patients contacting the ICB to raise issues with the service in the same way that we were with the previous provider. I think my sense on this is a long way away from where we were with the service that was provided by the previous provider. I think you used the term, Chair, truly atrocious. I would agree with you that the previous service was at times truly atrocious. I don't think this is in the same way. And I come back to the point that what we're looking at here is the satisfaction of patients. That's the key to this. And the measures that we've got so far of that satisfaction is generally good. We need to do more work on it. Fully appreciate that.
If I might,
if I
might, Tim, but you've given us July's data. You haven't given us January to July. So are we actually getting a reasonable look at what that feedback is? Because I don't think we are.
So I'm happy to provide further data to you. That's not an issue. So I think that, as I say, we've got a move away from having hard KPIs within the contract. That was a very conscious decision that the ICB took in going out to procure this new contract. I think coming back to the service delivery principles, we are fully aware that we need to do, and we are planning with and actioning with EMAS. We need to do better at those ones, the 3 that have been highlighted. So, but I don't think this is in the same league at all as the previous provider. Joy, do you want to come in?
Yeah, if I can just add, it's also from the service delivery principles. So from 2.3, for example, 92% of patients arrived before or within 30 minutes of their appointment time. So we also use that measure of how far away are we, and so from that perspective, we're not a million miles away from achieving those targets as well. So I think there's that level of information and detail that we use from the contract management perspective as well to be able to then see, okay, so where is it then that we need to make some improvements or some key actions to start to get to achieve those targets.
Okay, thank you. Councillor Cleaver, you'd like to come back in at this point?
Yes, thank you. Obviously, in the previous reply, there was reference to figures about compliance with the local incentive scheme, which are to be discussed on Friday. It seems to me a pretty obvious comment to make that those should have been included in this report because they're part of the whole picture about the performance of this service. So I'm quite unhappy that they're not there, given that they clearly exist and that the ICB considers them effectively to be more relevant than the figures against the principles which are non-statutory, which we've been given in Appendix B. And again, you know, one has to ask, given that one of these services is about people who are discharged from hospital to die in their own homes, it begs the question, and I hesitate to say it, but one wonders how many of the 50% of them that weren't collected within an hour of their book collection time actually took part in a patient participation survey. Thank you.
Do you want to answer that, Joy, or do you want me to come back on that one?
Yeah, from that perspective, for those patient types, we would not undertake a survey. So those patients, their death is imminent, and so there would be a number of circumstances those 4 patients would have fell outside of the parameter. But there was 8 patients in total, as I said earlier, and 4 that would achieve within the hour. There could be a multiple number of reasons. So, you know, where our resources were at the time that the call was received to be able to undertake the journey. So, but we would not survey those types of patients.
Okay, thank you. Councillor Allen, please.
Thank you, Chairman. A lot of my comments and reservations have already been raised by Councillor Cleaver and by yourself, Chairman. It does look as though the performance that is being monitored is showing not a significantly good picture. What is difficult to understand is whether that picture is changing from one year to the next. I accept it's only we're only in the second year of the contract. Is it second year or 2 full years have gone by? Second year, I think. And I listened to the comments about different ways of incentivising the contract and its performance with interest, but there are core deliveries that are required as well as these different incentives. And I think it's very important that we do understand, and the information is given to us quite clearly, that the performance, the new way of incentivising it is actually having producing the benefits that's actually required. Because it doesn't seem as though, from what we can see here as it stands at the moment, that is the case at all. So I think we need some consistent data that shows what the true picture is over a period of time. And that's not here as far as I can see. So it's very difficult to understand what is actually happening and whether these improvements that have been expected and perhaps being concentrated upon rather than the overall picture is actually happening. I think we do need another report fairly quickly to show that what we are being told is actually happening.
So we're very happy to provide further information, very happy to provide a summary of the local incentive scheme, very happy to provide a further report in a short space of time if that would be appropriate for the committee. So very happy to do that.
Chairman, can we also have something from the part of the trust that's actually responsible for this contract in terms of what they feel is happening and what their view is, rather than just the EMAS part, the contractor's part, in other words?
Sorry, could you clarify what you require there, what you're asking for there? So when you say the trust, EMAS are the contracted provider. The ICB commissions EMAS to provide.
You're the contractors. There must be some form. There must be a client responsibility within the local health service that's responsible for ensuring that the contract is working properly and it's providing the benefits that the new contractor is expecting.
So that's my role within the ICB, within the Integrated Care Board.
I'm sorry, in that case then it's you that I'm talking about then, isn't it?
Yeah, so so this is a joint presentation today. It's been a joint report written by the ICB with my view and written by the provider, which is EMAS.
So
Joy works for EMAS, I work for the ICB.
Councillor Allen, can you let him finish, please, before you come in? I think talking over people is not helpful. Thank you. Carry on, Tim.
I've finished my comment.
Yeah, I thought you'd finished. Sorry. My apologies then. I missed the subtleties of that, but quite clear that you're the client and you've read the report and hopefully got some concerns, and we'll be addressing those when we get the new report.
Absolutely.
Okay, thank you. I've got Councillor Wootton now, please.
Thank you, Chairman. Thank you for the report. I've got a question on page 84, please, and it's in the non-renal activity section. It probably speaks for itself, aborted journeys or cancelled journeys, but can you please explain how these come about? Is it because the public let you down, or is what actually goes wrong? That's my first question. And if you could answer that one first, then I'll go on to the next one, please.
Joy, do you want to take that?
Yeah, of course. So an aborted journey is a journey where we've started to progress and go to collect a patient, whether that's from a home address or a point of care. And when we arrive at the location, the patient is no longer travelling, and there's multiple reasons for that. And the highest reason for aborted journeys at the moment is through patients not cancelling journeys ahead of time because we're no longer required. And so as part of our improvement programme internally, we've undertaken some work around that to be able to have a communication programme around highlighting the need to cancel us ahead of time if we're no longer required. And so as you can see in the papers there, there's quite a number of journeys where that happens, and quite a lot of mileage is covered then, where we could then utilise that journey seat and time elsewhere to make improvements and use our capacity effectively.
And cancelled, I suppose they're related. Yes, yeah, thank you. So cancelled and aborted are related, aren't they? But I'd just like to say I became eligible for this patient non-emergency transport for some treatment I'm having. I live in Grantham, and I was referred to the Boston Hospital, the Pilgrim. So I've got lots of good friends that would have taken me there, but I used a voluntary care service, which was recommended when I rang up EMAS to book my transport. And that was a very good service for me to go out. It's cheaper than having a taxi, but although it's voluntary, you do have to pay. But that was great. It served me a good service. And I was booked for transport home. And when it's your first treatment, you don't really know how long it's going to take. So a time was committed between myself and the person I was speaking to, and EMAS turned up for me bang on time, but sadly my treatment hadn't finished, and he came back an hour later, and once again my treatment wasn't finished. But then it was recalculated, and EMAS came and picked me up. They were polite. Well, it was one gentleman. He was polite, caring and professional, and I felt that I got an excellent service. Thank you.
Thank you very much.
Okay, thank you. I've got Councillor Parkin next, please.
Yeah,
a lot of my specific points, particularly that one about the difference between aborted and cancelled, have been answered. I am slightly surprised that when the contract was in place that wasn't an obvious thing that we would have known would have happened, because I would have thought that's quite should have been a known risk that should have been mitigated for earlier on. And I think that's I recognise it's not as bad as it was, it's not as terrible as it was, but I still don't have the confidence it's quality. And without, I can't believe I'm ever saying this in a Scrutiny meeting, because I really dislike an over-reliance on quantitative data and figures. And it's something where I am the biggest advocate in the council is for us looking at the service user experiences and acknowledging that qualitative data, as Linda has just expressed so beautifully. But nonetheless, how can we scrutinise what we don't know? Now, I'm not suggesting that it's a disaster. What I'm saying is, without data, without KPIs, without that assurance, we can't scrutinise it. And so I think that's, in general, what I think we need to work on is, yes, we do need to look at the quality and all the rest of it, but we also need to do our jobs, and I'm not sure that we can at the minute on this.
May I come back on that? I think there's a balance to be struck here. There's a balance between having that holistic view of the service and having some hard metrics, some hard targets in the contract. We've consciously taken the decision, and this was an issue with the previous provider, we've consciously taken the decision not to have contractual KPIs within this contract. I think time will tell whether that was the right decision or the wrong decision. I take the point about how difficult that might make it for the contract to be scrutinised. But we are, as an ICB, getting feedback from patients. We're getting feedback from the services that patients attend and have patient transport taking them to. We are looking at the service delivery principles. They're deliberately not KPIs, contractual KPIs. We're looking at those service delivery principles, and we are asking EMAS to develop an improvement plan, an action plan around those where they are off track. And you've heard a bit about some of that improvement in terms of changed rotas. You've heard a bit about some of that improvement in terms of extending the number of bases. So I think this is a different approach to the more traditional approaches that we've had for managing the previous patient transport contracts. I think time will tell whether it's the right approach or the wrong approach. And the acid test of that is whether patients feel they are or are not getting a good service, and whether healthcare practitioners feel they are or are not getting a good service. From what we've seen so far, we think that patients are generally satisfied with the service. There are always going to be a number of patients who are not having the level of satisfaction that they want. We know that there are peaks and troughs, particularly around the renal service, and we're trying to do something about that. A visit to the renal unit this morning was very pertinent in that respect. So this is about continuing improvement. It's a different way of managing a contract, and I'm sorry if the committee feels that doesn't allow you the kind of the hard data to scrutinise the contract, but I'm happy to work with you to provide data that you feel and information that you feel would allow you to scrutinise the contract in a different way, and I'm sure Joy will do the same.
So we do have the data. So I'm really struggling to understand if we know the data, if we have the data, why that can't be used as KPIs and performance monitoring, and why we can't have that. I think I recognise, and I do genuinely, Chairman, welcome the looking at patient satisfaction and service user satisfaction, I think it's really, really important. But you don't know, we just don't have that assurance at all. For, you know, if I appreciate the attempt to recalibrate and balance the scales on what it is we're trying to measure, but I just think this is too far, and I actually think could send a really dangerous precedent in other contract monitoring that we have come to. So I am very, very uneasy, very, very uneasy at this point. And the thing is that without those key performance indicators, what it seems to me is that we're just going to end up stuck somewhere near the bottom, as opposed to that what we've seen with the brilliant presentation from Cancer Care earlier of, okay, so we're meeting those targets, what's next, what's next, what's next? So we don't just stick at the bottom, but the whole point of KPIs is that they're the road to improvement. And I don't like being critical at all in scrutiny meetings. I want to scrutinise, but this to me I think is just going too far.
So maybe there is something about working with the committee to understand what you would feel would enable you to scrutinise the contract in the way you wish to, or scrutinise the service, not necessarily the contract, but scrutinise the service in the way that you wish to. And I'm happy to work with that. What I don't want to do at this stage is change the principles on which we based the contract when we went out to procure it, because that's a whole raft of different issues around that. That might mean we have to go out and re-procure again, and I really don't want to do that. So happy to work with the committee on the basis of what would give you the assurance that this contract is good, bad, or indifferent. And happy to work outside of the formal committee meeting to do that. Don't know if that's an offer that you would find useful,
I think we appreciate that in one respect. The very worrying part of that is that actually you should be more concerned about the contract as much as we are, and the fact that this isn't being looked at in the manner that it was for the previous contractor, which you might say was potentially harsh and it didn't necessarily work for them. But you know, if you want someone to get those goals and get that performance right, then you haven't got a system in place whatsoever to do that. And that is incredibly worrying, I think, all over. And it's proving already that they are not delivering where they need to. And actually, what can you do to make them deliver? And I think that's the thing that we are incredibly concerned with. There just doesn't seem to be a mechanism. And we can continue on about feedback from patients, but at the end of the day, you're looking at a patient text message service. Most of your clientele, your customer base, whatever you want to call it, your patients that are using the service will probably be elderly and very unlikely to use a text message service. So how are you getting their feedback as well? The whole system is very concerning and worrying to me.
Can I come in on that? So through the contract monitoring that we have on this, you're absolutely right, particularly around the demographics of patients. And so part of that scrutiny is around, okay, so we've done text messaging, we've done other elements to gain feedback. So what's next? So what is it that we can do to gain a wider range of feedback as well? So it doesn't just stop at we've sent out some text messages and we find that that's acceptable. There's a lot of scrutiny that happens through the contract monitoring meetings around how we're going about that, what's the plan. So that was actually discussed at our last meeting. So from an ICB perspective, we are very much scrutinised and challenged around consistent and continual development and looking at a wider way of reaching out to people.
Okay, thank you.
If I can come back with respect, Chair, I think from my point of view, I do not want to have a service which is substandard. I've been involved in patient transport in Lincolnshire for the last 7 years. I do not want to have a service that is substandard. We do scrutinise what EMAS are doing. We do that in a slightly different way to the way we did it with HTG. I think we all know that it didn't work well with HTG. We are changing that approach because it didn't work well. So it's a different way of managing a contract. However, I talk to the various providers that use the service. We have representation from patients. We do scrutinise and hold EMAS to account. So I think there is that dialogue happening. What we haven't got, though, is the same KPIs in the contract that we had with the previous provider because they didn't work. So it's a real difficult balance, and I understand the committee's consternation on this, but it's a real difficult balance here to try and get something that works and drives improvement against having KPIs that providers are not going to necessarily meet. So there is a balance here, and as I say, I'm very happy to work with the committee outside of the meeting to provide you with an assurance process that you feel is acceptable.
Okay, thank you. It just seems we've got an old system that doesn't work and a new system that doesn't work. Councillor Smith, please.
Thank you, Chairman. That last comment is frankly staggering. It's not the KPI didn't work, it's that the previous provider wasn't fit to deliver a contract. It wasn't that the KPI didn't work. A KPI has a basic function. That is the standard. That is what you have to meet. You then, with a KPI, have a pain and gain metric in a lot of contracts we do here at County. And trust me, I sit on Unit Scrutiny as the Deputy Chairman. They work. What doesn't work is what we have. I can't scrutinise this. I can go to any of my residents and say, how's that? And often I had a resident who I was speaking to, and she has had, in a different arena but related to the National Health, she has had appalling service to the point that her and her husband have had to go privately, and it's cost them tens of thousands of pounds. But it took me to convince them to actually write to Sir Edward Lee and actually complain about it, because actually their argument was, what's the point? It's happened. I've had to pay it. And this is the same thing. It's not very British to sit and complain about something. It takes somebody like us and like me to sit there with them and say, no, actually, this isn't good enough. It's not just about you. It's about the next person that uses it and the next person and the next person. And Chairman, I have zero confidence in this, because that to me is not a contract. That to me is, we'll have a meeting, we'll say what we're doing wrong, but there's nothing in there with any teeth that says, right, this can actually hurt. If you don't deliver, this will hurt financially. There is a consequence to this. To use a forces term, Chairman, there's nothing in there that says we can have a meeting without coffee and a meeting where you don't sit down. If you come into my office and you say, and you help yourself to a seat in my family's background, it'd be, what do you think you're doing? This isn't one of those meetings. Stand to attention, you'll now hear while I give you a verbal ear bashing. And there's nothing in there, Chairman, that does that. And to say, oh, the KPIs didn't work. Sorry, they did work. The provider wasn't fit to deliver the contract. Those KPIs were absolutely appropriate for that contract, because I sat and reviewed them enough times. What we now have is something totally unfit, and this is a plea to the ICB. Please, for the love of God, do not expand this to anything else, because this is dangerous, Chairman. If this was something such as cancer care or other more immediate situations around emergency care, this is dangerous. It would be like saying to EMAS when they're doing emergency transport, the minimum standards an hour. Oh, by the way, but if you don't meet it, never mind. And I've had an instance of that, Chairman, where it wasn't met, and one of my residents, their wife actually died because they couldn't get an ambulance. But you don't see them saying, oh, never mind, we're not going to make sure that standard doesn't get met. I have zero faith in this process, and I can't scrutinise this, and you can offer any means in all the sundry out of this meeting to scrutinise it. But if there's no KPI, there isn't anything to scrutinise, because that's how you scrutinise a contract. It has a performance indicator. It has hard and fast metrics that work, that say, if you don't do this, Y happens. Not just on feedback, because, as I said, it's not very British to complain, Chairman, because most of the time they go, well, I was sat there for 3 hours, but what's the point? I'm home now. It's not going to make the blindest bit of difference. So I have zero faith this will work, Chairman, and with the greatest of respect to him, you can offer any which way you want. I don't think that will make any difference. I think actually what you need to do, and it's not going to be very popular, I actually think you need to retender a contract with KPIs in it, and KPIs that are hard, because actually if they're not difficult, then there's no point in them. They're meant to be difficult, they're meant to be challenging, because that's the point of a KPI and a contract and a pain and gain metric. And I don't think it was that they weren't fit. I think the previous provider wasn't fit for that service. Actually, I think the KPIs were very appropriate, and I said that in previous meetings, but this is a mess. And that's all I can say, Chairman, because I can't see how we can scrutinise this.
Okay, thank you. I've got Councillor Morgan next, please.
Yeah, thank you. It's almost, what do we say? First of all, I think we've missed the point about the KPIs, and it's been touched on. Your KPIs should reflect the patient experience. That's the whole point. They should be set so the patient experience is acceptable. So if you haven't got the KPIs, and I think it was touched on, you're doing lots of different monitoring and measuring because you've created a problem for yourself by not having those simple KPIs. You made it much harder to manage. The other thing I think we've forgotten about is the environment that we're working in, to be fair, but looking at it holistically. First of all, you're relying on the feedback from fundamentally people who are vulnerable and sick. So therefore, it is going to be much harder for them than people who aren't vulnerable and sick to respond. So you're relying on this soft data, and it's clear that there are gaps in that. If we actually look at measurements that are being taken, so the Operation of Service Delivery Principles table, what we can see there is there are some glaring issues. So flipping it around, the other side is what we should be able to do is say, well, where are things going wrong, and how can they be fixed? And there isn't really anything in here telling us what the actual problems are. And it might be that the issues aren't actually, it was mentioned earlier by Councillor Burke about the highways situation. What is causing the problem? Is it staffing levels aren't there? Haven't got enough ambulances? Is it that our ambulances are being stuck for an hour in a traffic jam or caught in potholes? What is actually causing the issues? These are the key things that actually we need to understand, or you need to understand operationally. Is it that the process of releasing patients itself is causing an issue and causing delays, just like we know is happening with the 999 ambulance services? I went to pick a friend up from Glenfield Hospital. She didn't rely on the ambulance service. She rang me up and I was for help, and I was happy to go. She rang me at 3 o'clock in the afternoon. She was actually released to be collected at 7:11 that night. So trying to actually manage a system for collection around that sort of environment is extraordinarily difficult. And it would have been easy to say, blame the ambulance for, but actually the real issue was the amount of time it took the hospital to release her. So I think this is actually, it's a very complex environment we're working in, but just having those basic measures start to raise the red flags as to where those issues are. And unfortunately, the trouble is without them, we're going to be pointing the finger at EMAS when it may not actually be their fault. And that's the problem. And I'm going to say, I feel the ICB have failed in their fundamental task. There's a reason across the country and the world that organisations use KPIs in contracts, and to somehow think magically we won't need to do it anymore is, in my view, a failure of management. And I sit on governance and audit on SK, and we would set, and I understand the work's been done here, lots of work in the background. You set those KPIs. It's a fundamental part of your job, and you haven't done it.
Okay, thank you. Yeah, carry on.
I would not agree with that, but I guess there's obviously significant concern by the committee, and we need to respond positively to that.
Okay, thank you. I've got Councillor Allen and Councillor Burke.
Thank you, Chairman. Chairman, if I remember rightly, I think we raised many of these concerns when we understood that the new contract for patient transport was being tendered in this particular way. And I think we also made comments about it had to be a very, very robust system if this is what was going to be intended in terms of a movement away from the KIPs to some other system. It had to be very, very robust and provide the actual management that was required of the contract and the patient improvements that was going to be sought, because I think this contract is something like 7 or 8 years. 9, is it? And that's a long time to operate a contract without any understanding of really what's happening within that contract. I think Councillor Smith made a comment about this is a model that should not be used anywhere else, you know, in the county, and I would fully support that. But the real question is what happens now, because I think the view is that KPIs are not in the contract, so they can't be used to actually manage the contractor. And we're left then with whatever is in the contract, which seems to be a little more than patient satisfaction surveys, coming from 350 responses from 152,000 journeys, which seems to me to be missing the whole point of what we're trying to provide, and actually being in the position to monitor this contract properly. And if we can't scrutinise it, I'm not totally sure how the ICB can actually monitor it either.
Okay, I've got Councillor Wharton, and I missed out first before I bring Councillor Burke, so apologies, Councillor Wharton.
That's fine, Chairman. Thank you very much. I must say, it must be really difficult to try and organise transport to and from hospitals for patients. And my question is, the ambulances must be able to take 10 or 12 people. Do you try and coordinate and put passengers together to go to certain locations? And does that affect timings? And also, hospital clinics, you have an appointment time, but they never, ever run to time. So another piece of market research, when I broke my thumb and I sat in orthopaedics, I'd watch lots of elderly people waiting to be transported home. And sometimes they're waiting over an hour or more. And is that some of the reason that this all falls down? That's it, Chairman. Thank you.
Do you want to answer that, Joy?
Yeah. Yes. We do try and coordinate. So we don't have vehicles that take out 8 to 10 people at a time. Obviously, over the previous years, there's patients have a higher level of acuity and need for us to support them. We do monitor through the contract as well in terms of our vehicle usage and how we can try and make the most of capacity, because you know on an average day, for example, we have 500 patient journeys, and they're all at different times and all from different locations, so that coordination is really challenging. And you mix that in with, you know, patients that need longer to be seen at times. And so you gave the example of yourself where we came twice for you because of you know, you weren't quite ready, and so we have that quite frequently, which is why it's really important for us to have that engagement with our healthcare professionals around. So what's next? What can we do better, and what can we do between us to ensure that we're providing that really good level of service, and also reducing the wait times, which links back into the service delivery principles. And so there's lots of variations that happen within patient transport that actually provides challenges, and it's just been previously mentioned around, you know, the road networks, any delays anywhere. You know, we can arrive at a patient's address and they're in distress, or there's something, you know, medical emergencies happened, and so we wait and support that patient, which then can have a knock-on impact with somebody else. So there's lots of day-to-day challenges that come up there, and I think it's really you know, a valid point in terms of being able to articulate that to yourselves, because that's how that level of scrutiny and detail we do provide the ICB, and so I think it's that understanding from yourselves what will help you to be able to scrutinise where we are, but also and give you that assurance that what we're doing is achieving positive patient experience as well. So absolutely understand the points, and so you know, on reflection around, you know, you wanting to understand and know that around the patient feedback, there's also again that assurance that you know, I now understand that you need in terms of the report and how that can look going forward, and so welcome some feedback and some insight on that will help us to be able to give you that assurance. But we have all that detail, we have all those challenges, we work with patients, we work with multidisciplinary teams, we can link in when patients are using the A&E service, and also that using the PTS service, so that we can provide support there as well. So there's lots of things that we do that perhaps that paper doesn't articulate, and give that assurance that Tim at the ICB and the quality team at the ICB do scrutinise us in terms of those service delivery principles. Hope that answers the question.
Okay, thank you. I've got Councillor Burke for the final comment.
Thanks very much, Chair. And I think Joy's closing remarks were very helpful in the sense that there's clearly an understanding that we're struggling to scrutinise the service. It's not just scrutinising the document or scrutinising the senior management team, it's scrutinising the actual delivery of the service. And I think, speaking as somebody who's managed the service, nothing like as large as this, but had managed services and found key performance indicators were useful, not an infallible tool, but one of the many important tools that any manager should have in their toolkit. So I think what would be really useful is, in the first place, for us to have a better understanding, I think on both sides, of the only document that appears to be available, the non-emergency patient transport criteria, which appears to be a national document. I think there needs to be a report that takes that on board and its recommendations, which is absent. It's referred to, but it's absent. It says there's no local guidance. I think clearly someone somewhere should be addressing that. But what I would like to see, and I wasn't on this committee for the previous contract, but what I would like to see is what measures are being used, not just patient satisfaction, but what measures could I, if I were a manager, use to ensure the service's delivery. So we need it proving to us the service is being delivered well, and then be able to make a judgment about change that is needed, because clearly members of this committee are getting feedback from patients who are not satisfied, and probably from managers in various parts of the service, I suspect, who are not satisfied either. So I mean, I would say to Joy that in a positive way, that we're not looking to be overly critical of you people. We're looking for you to come back in a way where we can be supportive and have a good analysis and a good scrutiny, Chair.
Yeah, fully agree, Councillor Burke. Thank you for that. And I think it's, you know, how you come up with the system KPI is the most logical way of doing it, and it's been tried and tested for many contracts for many years. So it does seem a little bit of a no-brainer, but I'm just completely aware that we're running over time now. So very last comment, Councillor Morgan, because I do need to move on. People want to go.
Yeah, thank you. It's just going back to what we were saying about what we could look at and what the issues could be. We've talked about patient experience. We should be asking the staff as well, just to make that point.
If I may, we do ask the staff. We ask the staff in the hospitals. We work with the staff in the hospitals and the community hospitals. So I was at the renal unit this morning gaining feedback. So that's a key part of this.
Okay, thank you. I'm going to move to a proposal now that the contributors be thanked for their presentation to the committee, that the importance of the non-emergency patient transport be recognised as an important means of enabling patients to access NHS services, and that due to the severe concerns that this committee has, that we actually have a report back in November of this year to update us. We'll have conversations probably outside of the meeting, Tim, in which manner we think that would be useful to enable us to scrutinise better, but I think from the comments that you've heard today, I'm sure you've got an idea of the sort of areas we're wanting to look at and cover. So do I have a seconder for that? Thank you. All those in favour, please show. Again, that's supported unanimously. And once again, thank you, Tim, and thank you for your time today as well. And to Joy, we appreciate it. Thank you.
Thank you.
Now move on to agenda item 8, the work programme. Simon, who waits patiently every time of the meeting goes for the very end. Over to you.
Thank you, Chairman. If I could ask the committee just to look on pages 86 and 87. The number 3 for the 9th of October, the implementation of the Mental Health Community Rehabilitation Service. The committee may recall that there was a report being commissioned from the East Midlands Clinical Senate. That report has now been received by LPFT, but they just want to look at 1 or 2 issues with that. So they are asking to, well, they are saying that they can't bring anything before November. But what the LPFT want to, if you like, substitute a report on their mental health inpatient pathways, because I think there are some issues there that they wish to raise with the committee. So it's kind of like 1 in, 1 out on that. And obviously we've just going to list another item for November. So I may need to look at the list for November in terms of perhaps moving stroke and nuclear medicine from that, but we'll just have to see how that fits. But yeah, I don't know if anyone's got any other questions or items for the work programme. Thank you, Chairman.
Cleaver, I think you're about to raise.
Sorry in advance if I'm going off on a slight tangent here, but given what was just said in the debate there, it sparked a thought in my mind. I wonder if we could do at some point an investigation report from the ICB about its emergency preparedness, how good its relationship is with the Lincolnshire Resilience Partnership, how good its plans are if a hospital or a GP service were to be flooded. You get where I'm coming from, that emergency planning is an important thing. We had major flooding events this spring of this year. That could be repeated. I'd like to know what the preparedness is. Is there a plan? Would the non-emergency transport be completely immediately mobilised to move people out of care homes if there was a major flooding, for example? That kind of stuff.
I'll hand over to Simon because I think you do flood and water management committee as well, don't you?
Yes, that committee is currently on my list. And I think my first, if the committee wished to pursue that item, I think the first people I would go to would be the people at the LRF, just to see if they could help us out there, but also get the ICB involved as well. I mean, I know that as a result of what happened over the winter last year, storms Babette and Henk, there were some impacts, but not major impacts on the NHS. Generally, things were okay as far as the health service was concerned.
Yeah, I mean, thank you for that. I'm just conscious that, obviously, as a dual hatter myself, I'm conscious that we are very aware at district council level of our involvement and our responsibility with the Local Resilience Forum, Local Resilience Partnership. We don't hear much about the NHS's interaction with it and don't have the reassurance about its readiness. And I'd just be interested to something for us to have a look at, that's all.
No, I think it's very worthwhile. I think the committee would be interested in that, so we'll certainly add that to the programme. Thank you. Councillor Morgan, please.
Thank you. Sorry, I feel like a stuck record sometimes, but because we had Grantham Urgent Treatment Centre earlier and separate from now, I'm conscious obviously they were still in their early days, but I think somewhere we should be reviewing them again in our programme, and they should become part of the overall picture, if you see what I mean. So I'm just not sure how best to deal with that. I have had concerns raised, and I'm not sure where's the best place to do it, whether it's when we're looking at resourcing and staff, or whether it's under that when the acute service review took place, we were assured that there would be, I think I mentioned at the beginning, that there would be a certain number of consultants provided, and they haven't been. In fact, only a quarter of them have actually been provided, so there's now concerns about the long-term status of the services being provided if they don't get those people and they're relying on locums, which they currently are. How sure can we be they'll carry on providing the services? So I don't know if it sits under staffing or if it sits under a separate review of the urgent treatment centre and part of that.
If I recall rightly, when we last looked at Grantham, it was said that it would now become part of business as usual, I believe, and then it would come as an update in the overarching, update in primary care services. So I think it's a worthwhile question. I think it would have been 12 months we'd have looked at Grantham again within that probably, but I'm going to bring Simon in because he'll have a clearer view. But in terms of in the meantime, I think it'd be worthwhile just asking the question directly with Pete Burnett. I know that we were assured when the acute services review happened, one of the questions was, what happens if you do not have the right staffing resources? Will we then be looking at you going from being 24 hours walk-in to a 12-hour because that's all that the requirement is for a UTC? And we were told categorically that would never happen. So I can reassure you on that part, but I think it's still worth asking the question, and I'll bring Simon in, please.
Just add, the other point that's been raised to me is that they were supposed to have a ward for the elderly, and they haven't opened that either because of the staffing issue. So, and given winter pressures going, I notice that's on our agenda as well, that could hit that.
Yes, so the decision back in July was to have further updates on the Grantham Urgent Treatment Centre combined with updates on the rest of the urgent and emergency care system, including the other urgent treatment centres. So the item this morning was effectively separated because it was actually the review which we know that they were undertaking, so that excluded Grantham. So they will all be combined at a later date. I think the specific staffing issues may be something, we've had a number of those raised up as part of the announcements, but they could be picked up. And maybe we would have to forewarn the presenters in January, but they could be picked up as part of the overall people strategy, which is still on the list for January. Thank you, Chairman.
Yeah, it seems like the logical approach, and we'll ensure that we do give that update. But as I say, in the meantime, we'll have a word with Pete Burnett and just see where he feels we are with the staffing situation. I do know that there is some element of services for the elderly that have been used as a ward in Grantham, so it'll be interesting to see what area that is and just get that full feedback, and we'll certainly happily ask the question and, as I say, try and build it into the people management in January. So, Councillor Mackinson-Saunders.
Well, following on from what Councillor Carver has said, I've been listening to some of the stuff from the COVID inquiry that's going on, and we would like to be reassured that adequate plans are in place for another pandemic. I know United Lincolnshire always had them, but that could be added onto that one as well.
Yeah, it all forms part of that recovery, so I think it would be logical that would form part of it. Very, very briefly, Councillor Morgan, I'll allow you back.
Yeah, thank you. It's a different subject, but same place. It's the old building, Grantham old building. I know that keeps being bumped. I've spoken to our planning officers, and apparently they are talking just about them renovating, restoring the current building and its fabric. But they've been told by ULHT that they're planning to review the whole thing in 2 years. And I'm not sure whether we should be reviewing their proposal us contributing towards their proposal, if that makes any sense.
We've raised this previously when you've asked about it, and it's under property services. From what I understand, they've got no plans at the moment in time to be in a position to do anything with it, is what we've been told. If something does come down the line, but at the moment it's been decommissioned, and so therefore it's not per se something that the NHS will come and speak to us about. And that is the email that we've basically received. I don't know if you want to add anything to that, Simon, or that basically covers it.
Well, yeah, yes, basically that is the answer. I mean, in a sense, you could say that while the building is not being used for NHS patient purposes, it's kind of falling just outside of the remit of the committee, although that might not be a very helpful answer in these circumstances. But I know that there have been lots of discussions about that particular building. And I do recall some years ago, there were plans for it to be used in some sort of clinical hospital way, but it's not being used at the moment. And it's just one of those things where, as we know from other sites in Lincolnshire, for example, Louth, where a large part of the hospital is, well, just not used. It's just buildings that aren't used. But this kind of is something that falls just on I suppose, on the edge of the remit of this committee, but it's something we won't lose sight of. But I'm not sure it would be in the committee's role to review a property plan for the NHS. I don't know. I'm not sure.
Okay, thank you. Okay, anything else? No, in which case I think we're all happy with the work programme moving forward. Thank you all very much for your contributions today and for your attendance at committee, and we'll look forward to seeing you next month. That brings committee to a close. Thank you.